second year resident at MNJ Institute of Ophthalmology. I am presenting the rare case of morning glory syndrome with TRD, tractional retinal detachment obscured by mature cataract. Introduction. Morning glory syndrome is a rare congenital anomaly that affects the optic disc, which is the spot where the optic nerve enters the eye. It is characterized by funnel-shaped excavation of the optic disc resembling the appearance of morning glory flower. This condition can cause visual impairment, including and can lead to vision loss if not properly managed. A case history: a 5-year-old Hindu male patient presented to us with a complaint of right eye leukocoria since 5 to 6 months. Negative history: no history of congestion, trauma, or any significant past history. Patient had no ocular complaint in left eye. On ocular examination, right eye, both eye subjective correction was iris pupil was normal in shape and size and reacting to light. Lens was mature cataract with lens displacement. Extraocular movements was full. Digital tension was normal. On undilated gonioscopy, open angle with normal structure seen. On left eye, there is normal finding. On right eye, due to MedCat, we cannot see the post segment, so we can beam mode ultrasonography. In beam ultrasonography, suggesting of retinal detachment. So we advise lens excision with vitrectomy with laser photocoagulation with silicone oil insertion was advised for right eye. On intraoperative finding, right eye complicated cataract with morning glory disc with tractional retinal detachment with pre-retinal band, retinal technique was found. This is the post-operative OCT photo and post-operative fundus photo. There is clearly excavation of the disc was seen. Result: clinical appearance of supernumerary vessels from the disc with glial tissue at the center is consistent with the disc dysplasia clinically resembling morning glory disc. Post-operative vision was HM plus, PL plus and PR defective. Eye patching every day for 1 hour for the left eye is advised. Explained very guarded visual prognosis for the right eye as the retina appear with disc dysplasia. In conclusion, we must analyze the posterior segment with all the necessary investigation, especially in case where the posterior segment is obscured for any reason, as the MedCat or any corneal atrophy. The rare diagnosis may be concealed with it. Differential diagnosis of the morning glory syndrome. The coloboma or optic nerve aplasia. In coloboma, large excavation corresponding to embryonic closure lead to retinal vessels exit in branching fashion. Association with Char syndrome, Walker-Walk syndrome, and Goldherner syndrome. In optic nerve aplasia, optic nerve was absent, head was absent, and blood vessels also absent. Cranial abnormalities associated with cranial abnormalities and facial abnormalities. On B scan, there is absent optic nerve shadow. There is no article published or case reported in which morning glory syndrome was found obscured by MedCat and associated with tractional RE. These are the references of the case.
Hello. You can easily make out the coloboma
in occupational eye safety. Method and materials. The 36-year-old male patient, welder by occupation, presented with complaint of gradual diminution of vision in both eyes for past 4 to 5 months. He had a history of chronic exposure to welding light without protective eyewear. There were no history of prior ocular surgery, systemic illness, or any family history of ocular disease. Personal history was significant for tobacco use for 10 years. The ocular examination, the best corrected visual acuity in right eye, it is 6/6, and left eye, it is 6/18. The anterior
Recording
segment
in
is within
progress.
normal limit. The color vision it is also normal. The fundus examination in right eye, the disruption of foveal contour with altered ellipsoid zone. There were no hemorrhage or no edema. Optic disc it is within normal limit. In left eye, post-welding maculopathy, disruption of foveal contour with altered ellipsoid zone, no hemorrhage or edema. Optic disc is 0.3 CDR. This is the OCT finding and visual field. There is shown a loss of retinal pigment epithelium also. And foveal contour also not maintained. Results. Structural damage was evident on OCT finding with macular hole in left eye and early photoreceptor disruption. Visual field collaborate with macular damage with corresponding paracentral scotoma. No systemic association were identified. The patient was advised retinal referral, multivitamin support, and mandatory use of welding filters. The welding maculopathy is photochemical retinal injury resembling solar retinopathy in presentation but caused by exposure to welding arc radiation. The injury predominantly affects the macula, particularly the photoreceptor retinal pigment epithelium complex. In this case, bilateral involvement with a unilateral macular hole indicate the chronic exposure and highlight the damaging potential of UV and blue light spectra in welders. OCT remained the investigation of choice to detect the subtle ellipsoid zone disruption and macular hole. Education regarding the safety glasses and filter shield is essential in prevention. The conclusion is post-welding maculopathy is preventable occupational hazard, often underdiagnosed or mistaken for solar retinopathy due to the similar retinal changes. Preventive is strict use of appropriate protective eyewear during the welding are essential. These are my references. Thank you.
Please collect your collect your certificate from Dr. Mayuri Bhai. Next paper will be presented by Dr. Janki and Dr. Nikita is there. Okay, please be ready.
Can we ask questions or why it happened only in one eye?
Good morning, everyone.
When the exposure,
My topic for paper presentation is tracing neurofibromatosis
Just a minute,
to
just a minute.
generation.
Sir, want to ask one question.
why this happened only in one eye when the exposure was in both eyes, equal exposure in both eyes?
Patient, when he do welding and exposure, then only one eye is affected because of the he do વેલ્ડિંગ કરતી વખતે એ જોતો હતો ત્યારે આ સાઈડ આ રીતે થોડું હતું એનો ફેસ થયું છે એનું.
And you're sure-
Usually the cornea is affected first, that is epithelial burns. So it is difficult to reach that to the
Macula.
retina. Usually
Usually in these conditions, the posterior segment is not at all affected. The reason is the corneal epithelial edema occur first and patient comes always in emergency. After exposure, they are presenting to you after 3 to 4 hours. But we do not have seen any patient with a maculopathy, and usually they are bilateral affected the cornea. Thank you.
This could
Pre-existing also. Can you describe the other differential diagnosis for the same?
Other differential is the if there is a arpade detachment, arpade alteration. If there is a solar retinopathy. So there is a detachment or
Neurofibromatosis is classified as a neurocutaneous syndrome, which is a group of congenital disorders that impact organs which arise from the ectoderm. These organs include the central nervous system, the skin, the eyes. Neurofibromatosis itself is further distinguished in two classes, NF1 and NF2. Both types of neurofibromatosis have different presentation for ocular pathology, which can assist in identifying the specific syndrome type, along with manifestations of disease in the other body system. The present study examines a case series of 3 family members, the daughter, her father and the grandmother. Aim is to document and analyze the clinical features and ocular manifestations of NF1 across 3 generations of a single family, and to highlight the role of genetic counseling in managing inherited neurocutaneous disorders. A 2-year-old female child presented with left eye proptosis and complaint of watering and photophobia. General examination showed multiple cafe au lait spots over whole body, and tortuous examination showed left eye upper lid plexiform neurofibroma. This is case 2, a 35-year-old male, that is father of the female child, presented with multiple neurofibroma and cafe au lait spots all over body, along with inguinal and axillary freckling. Ocular examination of both eyes revealed no abnormality. Case 3, a 58-year-old female, grandmother of the female child, presented with multiple neurofibromas and cafe au lait spots over bodies. Axillary and inguinal freckling were present. Ocular examination revealed no abnormality except presence of leash nodules in both eyes. As a result, with examination under anesthesia of the female child and the fundus examination showed right eye 0.5 cup disc ratio with healthy neuroretinal rim, and left eye showed 0.8 cup disc ratio with superior thinning and nasalization of vessels. Trabeculectomy was performed in the female child and kept on regular follow-up. Thorough ocular examination of father and grandmother was done, counseling of the family was done, and nature of inheritance was explained. Neurofibromatosis is inherited in autosomal dominant fashion with 100% penetrance and can cause multiple clinical manifestations. Genetic counseling in such cases is necessary and multidisciplinary approach is required for optimal clinical management. NF was first described by von Recklinghausen in 1882. It is autosomal dominant and affects 1 in 2500 to 3500 people worldwide. In our case series, 2 patients fulfill 3 and 1 patient fulfilled 2 criteria out of the given by the National Institute of the Health in 1988 for diagnosis. Various mechanisms proposed to cause glaucoma in NF1 include direct infiltration of the anterior chamber angle by neurofibromas, secondary angle closure resulting from neurofibromas of ciliary body and choroid, fibrovascularization leading to synachial angle closure with neovascular glaucoma and developmental anomalies of anterior chamber angle. Cafe au lait spots and freckles on the skin are frequently present in NF1 patients. Freckling is found in approximately 80% of the patients under age of 6 and 90% of patients over 30 years. In our case series, these manifestations were present in 100% of patients. These are my references. Thank you. Thank you.
Nice presentation. Sir, please collect your check, Dr. Janki. Kakre, sir. Uh, Next, Dr. Nikita and Dr. Pranshu Patel. Please be ready with your paper.
Good morning. I'm presenting a case series on ocular surface injuries due to firecracker during Diwali in tertiary healthcare center. Firecracker-related ocular injuries are a significant public health concern during Diwali. These injuries can lead to temporary or permanent visual loss and substantial burden on emergency as well as in ophthalmic services. Fireworks may lead to superficial ocular injuries, but also to severe trauma to whole globe and surrounding tissues. The injuries reported range from conjunctival or corneal burns to whole globe rupture with interventions ranging from ocular surface wash to repair of globe perforation. The aim was to evaluate the clinical profile, the severity, management, and visual outcome of the ocular injuries caused by firecracker during Diwali as presented in our tertiary healthcare center and to was taking 25 at a tertiary healthcare center with ocular injuries due to firecracker. Visual acuity was noted using Snellen's. The patient underwent a detailed ocular examination, ultrasound, A scan, B scan, gonioscopy, and fundus according to the as and when indicated. The following variables were noted: age, gender, type of firecracker responsible, severity of injury with respect to active and passive participants, management, severity of injury, visual outcome with respect to type of firecrackers. The injuries were graded according to the permanent eye trauma terminology. Most patients with closed eye injuries were treated on outpatient basis. Admitted cases include patients with corneal and scleral tears, traumatic iridodialysis with hypema, suspected IOFD and globe rupture. The results are as follows. I have depicted in the form of a pie chart. Most of the patients were in the younger age group, that is between 20 and 30 years of age. Most of the patients had superficial foreign bodies and are followed by contusion and laceration. Males were more commonly affected than females, and most of them had good visual prognosis, good visual field, visual vision, more than 6/12. My results were as follows. Out of 25 patients, most of them were bystanders as compared to the active participants. The severity of injury was more in the active participants. Bombs were responsible for causing injuries of more serious nature. 9 patients out of 25 patients required surgical intervention and indoor admission. 4 patients had open globe injury, rest 21 had closed injury. Saline wash, removal of foreign body, antibiotic and cycloplegic application were the mainstay of the treatment, managed conservatively. 3 out of 25 patients injured by firecrackers in our study became blind with the affected eye. Discussion. The injuries reported in our study range from conjunctival or corneal burns to globe rupture with interventions ranging from ocular wash to repair of globe perforation. Most patients within our study were less than 30 years of age. None of the injured was using
Elevated IOP remains the most significant risk factor. POG has a multifactorial etiology that includes genetic, environmental, vascular, and anatomical component. Aim and objective to study various etiological factors associated with POAG, to analyze the clinical presentation of POAG in patients, to emphasize the importance of screening and early detection. Material and methods. A cross-sectional observational study was conducted over 4 months in OPD at tertiary care center. Total of 50 patients diagnosed with POAG were included based on clinical evaluation. Each patient underwent dilated history taking, including family history and conioscopy to confirm the open angle for and perimetry. Inclusion criteria are age above 40 years of age, confirmed diagnosis of POAG based on IOP, disc changes and open angle. Inclusion criteria are angle closure glaucoma, secondary glaucomas, and history of ocular trauma or surgery. Results. Risk factor in POAG patients: out of 50 patients, 40 patients are more than 21 mmHg IOP. 9 patients have positive family history, 12 patients is a diabetic, and 15 patients are hypertensive. 7 patients have myopic, and more than 43 patients have more than 50 years of age. Clinical presentation: there are 62% patients are asymptomatic and diagnosis on routine examination. 10% patients come to complain with headache and eye strains. 24% patients have peripheral vision loss, and only 4% had tunnel vision loss. Optic nerve and visual field findings: out of 50 patients, 35 patients has more than 0.7:1 CDR ratio. 38 patients had significant thinning of RNFL, in which 14 patients developed arcuate scotoma. 12 patients has nasal stiffening, and 7 patients had paracentral scotoma. Discussion: this study confirmed the POAG often present asymptomatically, underscoring the need for routine screening. Elevated IOP was found in 80% of cases, through 20% had normal tension glaucoma, highlighting the need for comprehensive assessment beyond tonometry. Advance is more than 50 years. Hypertension and diabetics were common, supporting vascular contribution to POAG. Family history was noted in 80% patients, aligning with known genetic risk. Structure damage and RNFL thinning were prevalent. Visual field defect include arcuate scotoma, nasal stiffening, and paracentral scotoma, typical of glaucomatous loss. Multimodal evaluation, early screening, and public awareness are crucial to prevent late-stage presentation and vision loss. Conclusion: POAG remains a major challenge due to its silent progression. This study reaffirmed the necessity for comprehensive eye examination, especially for individuals over 50 and those with systemic risk factors. Resilience solely on IOP screening may miss significant cases. Structure and functional testing must be emphasized in regular practice to reduce the burden of irreversible blindness from POAG. These are my reference. Thank you, sir.
Have you asked for steroid use? Any history of steroid use? You have not asked that. Very common.
Okay. Okay, please collect your certificate from Dr. Mayuri Ben. And next will be Dr. Namrashi, and after that, Dr. Dhruvi Shah is there. Dr. Dhruvi Shah. Dr. Aarti Patel. Okay, please be ready. Now start, Dr. Namrashi.
Good morning. The topic for my presentation is silent invasion, a case of endogenous endophthalmitis in a pediatric patient. The aim is to report a rare case of endogenous endophthalmitis in a pediatric patient and to emphasize the importance of early diagnosis and timely treatment in preserving visual function. Endogenous endophthalmitis is a rare but severe intraocular infection caused by hematogenous spread of pathogens from systemic sources, although in 44% of cases, no source is found. It is most commonly associated with diabetes mellitus, immunosuppression, long-term corticosteroid therapy, IV drug use, indwelling catheters, systemic infections such as endocarditis and UTIs. Clinical features often include decreased vision, eye pain, redness, anterior chamber inflammation, posterior synechiae, vitreous haze, membranes, and exudates. Due to its often subtle and variable presentation, diagnosis is frequently delayed. A 6-year-old male patient was referred with a 4-month history of progressive bilateral diminution of vision. The symptoms began after an episode of systemic febrile illness, which was associated with gait disturbances. There was no history of ocular trauma or prior ophthalmic surgery. Systemic workup was done for fever and gait abnormalities, and the patient was diagnosed with demyelinating disease under investigation, for which he had received 2 courses of intravenous methylprednisolone for 5 days each and IV immunoglobulins. On examination, the visual acuity of both eyes was counting fingers at half meter, not improving with subjective correction. The anterior chamber Endogenous endophthalmitis is an uncommon but serious intraocular infection typically arising from hematogenous spread. Due to its rarity and non-specific presentation, diagnosis is often delayed, increasing the risk of irreversible visual impairment. This case emphasizes the importance of maintaining a high index of suspicion when a child presents with acute visual decline in the context of recent systemic infection. Moreover, this case highlights the importance of interdisciplinary collaboration between ophthalmology, pediatrics, and microbiology teams in managing such complex patients. Concluding, endogenous endophthalmitis, though rare in children, should be considered in cases of unexplained vision loss following systemic infection. Timely recognition, thorough systemic evaluation, and rapid initiation of targeted antibiotic therapy are essential for preserving vision and achieving favorable outcomes. These are my references. Thank you.
Please collect your certificate from Dr. Kakade, sir. Dr. Misha Patel, be ready. Dr. Misha Patel, okay. Now, Dr. Arti Patel, please start. Just a minute, Okay. Just a minute. Now we can proceed. Yes, start.
Good morning, everyone. My topic is assessment of the prevalence of a dry eye disease among the medical students. Introduction. Dry eye is defined as a multifactorial disease of the ocular surface manifested by the ocular symptom in which the tear film instability, hyperosmolarity, ocular surface inflammation, neurosensory abnormality play etiological role, produced by the inadequate interrelation between the lacrimal film and ocular surface epithelium. Dry eye disease is influenced by the various factors such as the geographical area, exposure to sunlight, windy condition, contact lens user, exposure to air conditioner, ametropia, and usage of the drugs like cyclosporin, excessive screen time. Symptoms of the dry eye include the watering, grittiness, foreign body sensation, sensitivity to light, red eye, and burning sensation. Due to the variable prevalence of the dry eye among the medical students, in different studies, we conducted these dry eye studies. Aim and objectives. The study aimed to assess the prevalence and associated factor of symptomatic dry eye among the undergraduate student at SBKS Medical College and Research Center, Vadodara. My study design is the cross-sectional institute-based study, which was conducted in Department of Ophthalmology, Tiraj Hospital, Vadodara. Duration of the study is around 12 months. Sample size is for 156 students. All the undergraduate medical students of age 18 to 25 years who gave consent were considered for the inclusion of the study. A student with the active ocular infection and suffering from any systemic disease during the study period was excluded. After taking the consent, they were clinically examined for the dry eye disease. A study was approved by the Institutional Review and Board and Ethical Committee. A total 156 medical students were included in the study, and Ocular Surface Disease Index questionnaire was used for the subjective assessment of the dry eye symptom in the young population. In addition to OSDI questionnaire, other details included were gender, presence of refractive error, exposure to air conditioner, the usage of visual display unit. A OSDI score was calculated on the scale 0 to 100, with higher score representing greater disability. As per the OSDI score, a dry eye disease was classified as the mild, moderate, and severe. A data was statistically analyzed using the chi-square test. P-value less than 0.05% was considered clinically significant for the variable associated with the dry eye disease. Observation and result. A prevalence of the dry eye in medical student as per the OSDI grading is a normal 51%, in mild 22.9%, moderate 10.3%, and severe 15.8%. Prevalence of the dry eye was 46.1 among the medical students. Prevalence of the dry eye in female was 46.4% and in male 45.7%. OSDI score more than 30 was seen among those with long usage of visual display unit for more than 6 hours and was about 52.6%. A total number of students wearing spectacles were 110, of whom 59 did not have dry eye and 24 had mild and 9 had moderate and 18 had a severe dry eye. Discussion. Dry eye disease is one of the most prevalent ophthalmic disorder and may have an adverse impact on quality of life. In addition to causing various disabling symptoms, it may also compromising the result of corneal, cataract, and refractive surgical procedure. In our studies, OSDI questionnaire was used to assess the dry eye disease among the medical students. Is it specific for the dry eye disease? Is inquired into the presence and frequency of specific symptoms and their impact on the vision-related functioning. The OSDI has a good to excellent reliability, validity, sensitivity, and specificity. Conclusion. In the conclusion, the prevalence of dry eye was 46.1% among the medical students. There was a significant association between the dry eye and longer duration of the visual display unit usage of more than 6 hours. For my reference.
Any query? Okay, please collect your certificate from Dr. Shashi.
46.1% is too huge a percentage she claimed for. You said 46.1% for the students. It's a huge.
Yes, sir. So out of 156.
It is not so. That's what I mean to say.
Okay, please collect your certificate. And now Dr. Drashti Patel. And after that, Dr. Misha is ready. Okay. Okay, please start.
Good morning, everyone. I am presenting paper of structural and functional relationship between retinal nerve fiber layer damage and visual field defect. Glaucoma described as a group of condition in which there is characteristic cupping of optic disc with corresponding visual field defect due to retinal ganglionic cell loss. It is progressive condition. Its most common cause of irreversible blindness worldwide. Primary open-angle glaucoma is subset of glaucoma defined by an open, normal appearing anterior chamber angle and raised intraocular pressure with no other underlying disease. Automated static visual field perimetry Humphrey is a gold standard for diagnosis and monitoring open-angle glaucoma. It has been established that 50% ganglionic cell need to be lost before field defect become apparent. Visual field defects that are characteristic of open-angle glaucoma are nasal strip, generalized depression, arcuate scotoma, localized defect respecting the horizontal meridian. RNFL.
Excuse me. Your topic is, I think, on sympathetic ophthalmitis.
एक्चुअली वो पोस्टर का टॉपिक हमने पहले सबमिट किया था, फिर
अच्छा।
पेपर था तो अलग चेंज कर.
ओके, वो पेपर पेपर के लिए था, बोल रहे हैं. ओके ओके, कंटिन्यू.
RNFL thickness may serve as useful adjacent in accurately and more objectively distinguish normal from glaucomatous eye and even in early stage of glaucoma, and may help to differentiate various severities of glaucoma. OCT is a non-contact, non-invasive diagnostic technique that allow measurement of RNFL thickness by in vivo visualization of retina and RNFL with a good reproducibility. OCT determined RNFL thickness has been shown to be significantly reduced in patients with glaucoma, although with inter-individual variability. Open-angle glaucoma is divided in 4 parts for the study. Early case of glaucoma with optic disc ratio less than 4 with raised intraocular pressure. Moderate case of glaucoma with cup disc ratio 0.4 to 0.6 with neuroretinal rim thinning. Severe case of glaucoma with cup disc ratio 0.6 to 0.8 with neuroretinal rim thinning. Advanced case of glaucoma with 0.8 disc ratio to total neuroretinal rim thinning. Aim to study the role of retinal nerve fiber layer analysis by OCT and visual field changes by perimetry for monitoring patient of open angle glaucoma at different stages. Inclusion criteria or patient diagnosed with primary open angle glaucoma come to our OPD. Exclusion criteria: secondary glaucoma, other ocular comorbidity, history of eye surgery or angle closure glaucoma. Results are majority case present in the moderate stage of glaucoma and majority of them has family history. Among 100 primary open angle glaucoma cases, 21 cases are early stage, 34 moderate, 32 severe and 13 cases were advanced case of glaucoma. Among them, 76.19% case of early glaucoma shows neuroretinal rim thinning and rim asymmetry, but only 23.8 case has the visual field defect. 70.5 case of moderate glaucoma shows RNFL thinning and rim asymmetry, but only 29.41 case has visual field defect. In severe case, 81 and in advanced case, 85 shows RNFL defect, and among all of them has visual field changes. Conclusion: the structural functional relationship is more stronger in late and advanced cases of glaucoma than in early stages. Dynamic range of measurement and intersubject variability suggests that RNFL layer analysis may be more sensitive for early glaucoma and perimetry is better measure for moderate and advanced glaucoma. Thank you.
What do you think from your study? Which one is the first to pick up the defect? In early case, you said no. Or which one was?
The RNF discosity liable. Perimetry so defect visual field.
No. It is. We don't want to discuss the literature. Your experience. What was the first one to pick up?
Madam, it was RNFL. She showed 70% plus in all stages. That is what I want to ask you, whether RNFL gets affected first or visual field. He projected RNFL 70% plus affected in all stages and 25%.
Let her explain, Ashish. This is for them. So in mild case of glaucoma, if you have diagnosed only based on the RNFL, then it is not correct diagnosis. Was there any field loss in those patients?
Early there is not all of the patient is not shown.
So those are ocular hypertensive, not the POAG case. Okay.
Now Dr. Misha Patel, and after that Dr. Harshita is there, and Dr. Devyani. Okay, please be ready, and last Dr. Mrugang. Dr. Mrugang is there? Okay, okay. So be ready with your paper. Now start, Dr.
Good morning,
Nisha.
everyone. The topic is to study the various causes and glaucoma. Glaucoma is a group of eye diseases that damage optic nerve pathway chemical information. Damage often caused by increased pressure within the eye can lead to progressive vision loss, even blindness if left untreated. While primary glaucoma has no identifiable cause, secondary glaucoma arises from underlying eye disease or systemic condition. Secondary glaucoma presents a unique challenge for ophthalmologists. Unlike primary glaucoma, where treatment focuses mainly on lowering IOP, secondary glaucoma requires identifying the underlying cause. This study aims to delve into the various causes of secondary glaucoma. We will explore both secondary open-angle glaucoma, where the drainage channels for fluid within the eye become blocked, and secondary angle closure glaucoma, where the iris blocks these channels. To study the causes and clinical presentation of secondary glaucoma in tertiary eye care hospital. Materials and methods. Thorough examination was done using visual acuity using Snellen's chart, slit lamp examination, intraocular pressure measurement by Goldman applimation tonometry, gonioscopy, optic disc examination, visual field testing. Study type is cross-sectional, sample size is 40, study duration is 2 months. Results were silicone oil induced glaucoma is the most common cause of secondary glaucoma, that is 22.5% cases. The second cause is traumatic glaucoma, that is around 20%, followed by pseudoexfoliation and lens-induced, neovascular, and then steroid-induced. Discussion. The causative factors usually overshadow any symptoms or signs of secondary glaucoma, so that the diagnosis is frequently missed and almost invariably delayed. This is largely due to the lack of knowledge regarding the relative frequency of various causes of secondary glaucoma. There are limited studies and limited data available on secondary glaucoma. The prevalence of these cases varies from study to study. In population-based Arvind Comprehensive Eye Survey, 3 from South India reported a 0.7 incidence of secondary glaucomas, but the total prevalence of glaucoma was 2.6, that is the third of all glaucoma cases. The most commonly seen causes are silicone oil-induced, traumatic, lens-induced, neovascular glaucoma, while ghost cell glaucoma and pigmentary glaucoma being comparatively rare. Prevalence of various clinical presentation varies with various types of clinical signs like pain, diminution of vision, can be painless or painful, nausea, vomiting, redness, headache, colored halos. Conclusion is, during my study, various types of secondary glaucoma have been noted, out of which silicone oil induced, that is 22.5%, was the most common cause, followed by traumatic, that is 20%. Most patients presented with a diminution of vision, that is 70% cases, being the primary complaint associated with pain that occurs in 50% and redness most commonly. Therefore, secondary glaucoma needs early recognition and prompt management like primary glaucoma to prevent blindness burden worldwide. Thank you.
Okay, Dr. Jignesh, please give her certificate. Dr. Harshita. And after that, Dr. Mrugang is not there, no? Okay, please be ready.
Today I would like to discuss a case titled Ocular Clues and Alport Syndrome, a window into systemic disease. Abstract. Alport syndrome is a rare hereditary disorder affecting the basement membranes of kidney, ear, and eyes due to defect in type 4 collagen. Ocular manifestations such as anterior lenticonus and dot flake retinopathy can precede systemic symptoms and serve as early diagnostic markers. This case highlights the contributory role of ophthalmic evaluation in the systemic profiling and genetic confirmation of Alport syndrome. The aim of the study is to demonstrate how characteristic ocular features can aid in confirming the diagnosis of Alport syndrome. This case is of a 26-year-old male presenting with progressive vision loss since 1 year and a history of chronic kidney disease since 4 years and bilateral sensorineural hearing loss. A comprehensive ophthalmic evaluation was performed, which included slit lamp examination and fundus examination. Genetic testing was conducted to assess the mutation in COL4A5 gene. The case was reviewed collaboratively with nephrology and ENT specialists as a part of a multidisciplinary assessment. On slit lamp examination, a classical anterior lenticonus was found in both eyes. The vision of the patient was 6/18 partial in both eyes with -5 in both eyes. The patient had long-standing renal dysfunction and bilateral hearing loss. Genetic analysis identified a COL4A5 gene mutation confirming X-linked inheritance. Discussion. Anterior lenticonus and dot fleck retinopathy are specific ocular findings that reflect underlying systemic pathology. Recognition of these signs can reduce the reliance on invasive investigations such as renal biopsy. Genetic confirmation support alignment with the clinical phenotype. Ophthalmologists play a vital role in holistic diagnosis. A multidisciplinary approach involves the ophthalmologist, nephrologist, and ENT specialist for essential and timely diagnosis and comprehensive patient management. This case emphasizes the role of ophthalmologists in systemic disease evaluation and highlights the importance of multidisciplinary collaboration in diagnosing and managing Alport syndrome. These are my references.
Okay, nice presentation. Please collect your certificate from Dr. Chakadi, sir. Any other resident remaining? Okay, now you can start now. Dr. Mrigank.
Good morning, everyone. I am presenting a case report on retinopathy induced by the welding arc exposure. Aim of the study: to study the case of patients with photic retinopathy due to exposure to welding arc, and to emphasize the importance of early recognition and protective measures are crucial to avoid the long-term ocular morbidity. Welding arc emits the intense optical radiation, including ultraviolet visible and infrared lights, which can penetrate ocular tissue and cause keratitis and photic retinal injuries. The temperature of retina increases not more than photocoagulation threshold, and thus all injury is produced by photochemical effect from UV and short blue wavelength exposure. This case report we presents a case of bilateral retinopathy in a 38-year-old male welder who experienced decreased visual acuity and central visual disturbances following repeated unprotected welding arc exposure. It also discusses the symptoms, diagnostic method, and need for proper eye protection during welding, and the importance of the early diagnosis for better visual outcome. Materials and methods. A 38-year-old male presented with the complaint of blurry vision, central scotoma in both eyes, with a history of exposure to welding arc accidentally for multiple times over the last few months. On examination, visual acuity was recorded as a 660 in both eyes. Slit lamp examination, anterior segment was within normal limits with a clear cornea. Fundus examination suggestive of central macular changes as a yellow edematous lesion with retinal pigment epithelium disruption, along with inner segment and outer segment junction defect. OCT examination revealed mild disruption of ellipsoid zone in both eyes with central foveal thickness measured as 196 and 186 micrometer. Fundus images demonstrated a normal optic disc and yellow discoloration of the macula with subtle pigmentary changes in both eyes. Based on clinical imaging finding, a diagnosis of photic retinopathy was made. Bromfenac eye drop and a tablet multivitamin B complex in frequency of twice a day was given for retinal recovery. The patient was advised on strict eye protection during welding. Follow-up was scheduled to monitor visual changes. Conclusion: retinopathy from welding arc exposure is a preventable yet potentially sight-threatening condition. Early recognition and prompt implementation of protective measures are essential to prevent a permanent visual loss. Cases presenting with welding-induced photokeratitis, the possibility of the deeper photic retinal injury must be carefully evaluated. Optical coherence tomography are indispensable tool for accurate diagnosis and prognosis. Here, welding arc exposure can cause photochemical damage to retina. Photic retinopathy may occur even with brief exposure without protection. And when patient present with welding-induced photokeratitis, the possibility of photic retinal injury should be evaluated and offered the thorough examination should be done. Here are some references.
You mentioned photokeratitis and at the same time you mentioned slit lamp examination within normal limits.
Yes, sir.
You yourself are contradicting your presentation.
No, sir. Photokeratitis was not present in this patient. This patient has come after 20 or 25 days of the exposure. So I am mentioning the photokeratitis should, if patient arrives with photokeratitis after welding arc exposure, we should examine fundus examination also.
No patient slit lamp will be normal. Age of 35 is working that age with welding. And the complex doesn't help in retina, sahib. Ek comment karo. The carotene and all that, you need antioxidants that supporting.
Okay, Mrugant, please collect your certificate from Dr. Ashish.
So with this, we conclude this session, and next session will be at 9:15. Okay, now we can proceed for that. Dr. Santosh Honawar, sir. Okay. Before that, we have a group photo with all residents who presented the paper. Please come on dais. Next session will be the oculoplasty. Dr. Santosh Honawar, sir, Dr. Dhaval Rajpara, Dr. Bhavesh Patel, Dr. Mihir Patel, Dr. Dikshan Shioni, and Dr. Minesh Modi. Come on dais. We will start next session after 9:15.
Residents, don't run away. 9:15 is going to be your lucky session. You know, it's a rare phenomena to have Dr. S.H. Who is he? Dr. Santosh Honawar, the godfather for oculoplasty in over India and world. So you will get each and every micro details. So be seated to your seats.
We are going to start our oculoplasty session.
I welcome Dr. Ashish Shah, sir, to present his talk. Yeah, namaskar. I am happy that I have been projected first. Otherwise I was sandwiched between the national king in oculoplasty, Dr. S.H., and our Gujarat oculoplasty king, Dr. Shalin. We all are getting scared by the word cybercrime, cyber fraud in this digital era, but we should be very much digitalized and very, very much alert. And for me, I'm presenting Cyber Knife, the all new in our Bharat, It's only available in Gujarat and that too in Ahmedabad. Myself is Dr. Ashish Shah, onco-oculoplasty eye surgeon, Ahmedabad. The history for this Gamma Knife, Cyber and all that projects in 1949 by Dr. Licksell, Sophia Hospital, Stockham. And that radiosurgery was done for optic nerve decompression in pituitary adenoma. Why choose Cyber Knife for radiosurgeries? The surgery and radiosurgery. The difference is surgery incisions are required, general anesthesia is required, high-risk surgical complications are there, and prolonged hospitalization is there. While in these radiosurgeries, no incisions required, no general anesthesia, low risk of complication, and no or minimal hospital stay is there. And when to use this cyber knife, the so-called CK? The indications of cyber knives are for tumor lesions less than 5 centimeters. And those are benign and malignant. Benign are arteriovenous malformation, eye vestibular scavenoma, optic nerve meningioma, cavernous hemorrhage, a huge list. And in malignant, it can be used in lungs, brain, liver, spine, lung, and eye also. Various knives are available so far. So initial was Gamma knife, also known as Linex, since 1999, used mainly for 2 to 3 centimeter growth and mainly in cranium and up to C3, which uses cobalt 60. Then came the X knife, same as Gamma knife, but uses frames for which are fixed to the skull for near perfect and precise delivery of the radiation. Now new is Cyber Knife, CK. Cyber Knife, as it is said, is CK. It is a KUKA robot knife. It's an all-organ SRS. SRS is stereotactic radiosurgery. It's a frameless. It is real-time tracking. It's precise, perfect, bloodless, incisionless, sutureless. And the things used are collimators. The fixed external collimators. Then it's iris collimator, that is for mobile lesions. And recently multiple new is coming up. These are the frames which used to be used for gamma rays and X knives and all that, which immobilizes the lesion for perfect focusing of gamma rays. And it used to take months for manufacturing the making of the frames. And this is the frameless in CK knife treatment. Thermoplastic mask is prepared within 45 minutes, heating it up to 65 to 70 degrees centigrade, and the treatment starts. You don't have to wait for months like those fixed frames. And can be done in tracking movable lesions, 6D tracking for brain, skull tracking, spine tracking, X-site for our lung, eye tracking, synchronizing lung-eye movements tracking. Like yesterday, our Dr. Zala, we use wavefront technology in excimer lasers and all that. So similar systems are available in CyberKnife also. The delivery of the radiation, there are different methods. That is SRS, is stereotactic radiosurgery. The single dose of radiation to the tumor delivered mainly for intracranial orbital growths. FSRT is fractional skull radiotherapy. Radiations delivered in fractions in different settings in brain and eye. Then SBRT is stereotactic body radiation therapy. that is for beyond skull and brain radiotherapy. WBRT is wide body radiation therapy for large tumors. Mechanism of action, so far we all which are interested, is the precise and perfect radiation damages the DNA of the tumor cells, causing early cell death or late cell death, either or, and leading to the total tumor removal in case of early cell death, and permanent growth tumor control. It thus does both cures and controls growth tumor. Indications, as already said, brain, eye, lung, cavanomas, arteriovenous malformation, uveal melanoma, optic meningioma, glioma, adenomas. These are examples. One of the patients, Naran Bhai, had carcinoma right eye upper lid with lung metastasis. There is meningioma of Govind Singh Ji treated in right eye. You see this bilateral scaminoma. This is formula, they use it for application of radiations to the tumor. Please go to MC3, it's none of our business, but I need to project for all. Side effects which we all are worried always. There is radiation harness, it's said. That is tumor resistance to inoperative radiation doses. If you don't calculate radiation doses properly, then you'll end up with radiation harnosis. And it's organ at risk, that is OAR. If the size is more than 2.5 centimeter, the nearby organs are also affected, damaged. So the aim of CK is to cure, to control, and to relieve pain. So in conclusion, it's the precise, perfect, frameless, blurless, painless, sutureless, insulineless, you name it, you have it. And it's a real-time tracking, effective robotic radiosurgery for all organs. Goodbye big illnesses and goodbye big surgeons, because no more big neurosurgeons are required, and those big illnesses are no more there. Thank you.
Thank you, sir. So please collect your certificate. The panelists of the session, Dr. Kalpesh Rajput, Dr. Vikram Darji, Dr. Jignesh Jethwa, Dr. Amula Gandhi, Dr. Vipul Prajapati. Please, any one of these here, come to the dais. Thank you. Now we'll proceed with the lectures of Dr. Honhawa, sir.
Thank you so much for the opportunity. I'll be speaking very briefly about which intraocular tumors you worry about. When you see intraocular tumors, the spectrum is so wide that you can easily get confused. For example, if you see a lumpy, bumpy iris with shallow unilateral sectoral anterior chamber issue, then it could be a peripheral iris cyst. So you have to do UBM or anterior segment OC to differentiate a cyst from a solid lesion. Solid lesion is a melanoma. So unless you do anterior segment imaging, you'll not be able to differentiate a cyst from a melanoma. It's a curious combination of a cyst with a melanoma. So if you get fooled just with the cyst and ignore the peripheral shallowness of the anterior chamber, you may actually miss this vital melanoma that is lying behind. There are other cysts in the iris. These are called mid-zonal cysts, pupillary cysts, and a free-floating cyst. And of course, a secondary cyst. Now, iris melanoma can masquerade as secondary glaucoma. This was a 30-year-old young male with unilateral secondary glaucoma, which was diagnosed as iridocorneal endothelial syndrome because of correctopia, ectropion, UVA, etc. And somebody even did a trabeculectomy. But the patient actually had a melanoma. You can see after enucleation, that it had full thickness infiltrated the iris. There was a nodular posterior component. That's the bleb being infiltrated with melanoma. Under the scleral flap, there is melanoma. So this melanoma became extraocular just because UBM was missed in this situation. So how do you differentiate a pigmented iris tumor, melanocytoma versus melanoma? Always look at the pupil. If the pupil is nice, round and central, there is no correctopia or ectropia on UVA, no NVI, despite high pressure, you can clinically diagnose this as melanocytoma and not melanoma. One more example of a nice round pupil. This tumor is scary, but look at the pupil. It is beautifully round. There is no NVI. So this is melanocytoma, which is a benign tumor. This is a iris nevus, which is a benign tumor. Whereas now look at melanoma. Pupil is dragged towards the lesion and there is NVI. So both these are melanomas. Look at the pupil and you'll get a diagnostic clue. Patients with retinal exudates. This young patient has macular exudates, because of which he comes to you with loss of vision. Now there are three situations where remote retinal exudates can occur. Look at the periphery and you will find a retinal capillary hemangioblastoma. Following cryotherapy, the tumor is regressed and the exudation also goes away. So when you have macular exudation, retinal capillary hemangioblastoma is a possibility. By itself, it is not life-threatening, but because of its association with VHL syndrome, it can be life-threatening. If you look at this graph carefully, you find that it is the ophthalmologist who recognizes this first. Patients come to an ophthalmologist when they have retinal capillary hemangioblastoma. All other manifestations, renal cell carcinoma, cerebellar hemangioblastoma, etc., happen much later in life. So you have the first point of contact, and that is the reason whenever a patient comes to you, you have to do VHL gene test. And of course, screen them for VHL disease, and also the entire family needs to be screened. When you have a dirty yellow lesion of this sort, then it could be a choroidal metastasis. This is a patient with choroidal metastasis, a dirty yellow color with exudation. Exudative retinal detachment is very characteristic of choroidal metastasis. Multifocal bilateral yellowish, creamy yellowish lesions is very classic manifestation of choroidal metastasis. If you have a diagnostic dilemma, simply do OCT and you find shaggy photoreceptors and lumpy bumpy tumor surface. This is a classic description on OCT for choroidal metastasis. Now, if there is no SRF at all, in choroidal metastasis, generally there is subretinal fluid. Similar looking lesion with very little or no SRF, then that is choroidal lymphoma with retinal pigment epithelial changes. So choroidal lymphoma comes to you in a chronic situation. Metastasis is acute, subacute, whereas lymphoma is chronic. That's why RPE changes happen. That's why there is no subretinal fluid. And when you do OCT again, you find what is called the undulating tumor surface with overlying subretinal fluid. This is called the seasick appearance on OCT. This is just a vitreous haze. You should not confuse this with pars planitis. This vitreous haze is because of, or a cloud or clump is because of what is called retinovitreal lymphoma, which is primary intraocular lymphoma or CNS lymphoma. This is a deadly disease because these patients have association with CNS lymphoma as well, and it can kill these patients. So you have to very carefully investigate them. And the treatment of choice for ocular lymphoma is intravitreal methotrexate. 400 microgram given 3 weekly over 6 injections can take care of this. Of course, EBRT is also used. In orange colored lesion, if it is in the posterior pole and on B scan, you find choroidal shadowing or orbital shadowing, that is choroidal osteoma. But otherwise, choroidal hemangioma is the most common non-pigmented intraocular tumor. You can see choroidal hemangioma here. And if at all there is subretinal fluid, then you treat it either with PDT, which is currently not available, or plaque brachytherapy, which gives excellent success. In lesions of the retina, we have TERP, congenital hypertrophy of the retinal pigment epithelium, which is a very crisp retinal pigment epithelial lesion with RPE changes like this. It is associated with Gardner syndrome, which is polyposis coli. So if a patient has more than 5 of these TERP lesions or bilateral extramacular location, you should get them endoscopy. Now this is melanocytoma, of course, irrespective of its size, it is melanocytoma, very classic. The last bit is about how to differentiate choroidal nevus from a melanoma. Whenever there is a pigmented choroidal tumor, most likely it is a nevus because it's the most common benign intraocular tumor. It comes silently without any SRF. and it compresses the choriocapillaries. You can see normal choriocapillaries here. Here it is compressed. That's the choroidal lesion that we are looking at. And the retina gets very gently elevated. Now, RPE changes are there as part of the choroidal nevus. This is a classic melanoma. There is subretinal fluid. This, of course, is very familiar, Colestad melanoma, because of the break in the Brooks membrane. This component, nodular component, is manifested. Now, how do you differentiate this from a melanoma? This was a gastroenterologist from my own city, a very busy practitioner who had problem with vision. And when we looked at his fundus, we find a pigmented lesion, which is just 3 millimeter in diameter, hardly any thickness. And he did not accept the diagnosis of melanoma. He waited for 6 months. You can see obvious increase in size of the tumor. So how do you differentiate a nevus from a melanoma? Look at the thickness. Thickness more than 2 millimeter. Subretinal fluid, which is already there at its initial manifestation. Symptoms of loss of vision. Orange pigment, which is lipofuscin, which indicates metabolic activity. Margin close to the optic disc and fovea. These are the 5 indicators of a nevus from a melanoma. Of course, you can do OCT, etc. And plaque brachytherapy is the treatment of choice. And in very situations where the tumor is very tall like this, we excise the tumor. That's called lamellar sclerouvectomy. Larger tumors are excised. So in conclusion, I would say that in intraocular tumors, there are a lot of mimics which need to be differentiated one from the other. And of course, you have to expect the unexpected. Thank you so much. If Shalin can do the next talk, my next presentation has a technical problem, I will set it up. You have a talk, no? You can do the next talk and then I will come back again. Yeah.
Now I welcome Dr. Shalin Shah in this talk.
Thank you, sir, for the opportunity. Sir has already described what to look for inside the eye. I'll be talking something about what to look for outside the eye. And of course, sometimes inside the eye as well. So, what tumors do we expect? We can expect well-defined capsulated lesions like we can expect well-defined capsulated lesions like these, which are lacrimal gland masses. We can expect diffuse tumors like these, which are lymphomas and often bilateral. Then we can expect some huge cauliflower-like growths in children, which usually turn out to be late retinoblastomas. Or even in adults, we have some bad proptosis, which turned out to be a melanoma. And next we have the wares. So we have intraconal tumors which present with axial proptosis as seen in the first case, with a well-defined tumor well within the muscle cone, or we can have some extraconal tumors which present with abaxial proptosis, and the patient usually presents with a deviated eye, and we can see a tumor just above the globe. Next we have the Ys. So here we can have well-defined tumors with intra-tumor calcification, as seen in the first tumor, which are usually malignant. We can have other tumors which are compressing the globe, and these are again malignant tumors. Or we can have such tumors which have perforated the globe and moving outside, which are again malignant retinoblastomas. And how to treat them? So to take this patient from the first picture to the second picture, that is the point of our talk. And this patient, again, a similar tumor, the first to the second. So let's go on to some cases which we routinely encounter in our OPD and how to manage them. So we have a middle-aged lady here who presented with proptosis since 4 to 5 years. So a long history. Vision was less, hand movements, and disc was pale. On imaging, we see a well-defined mass within the cone, and we can see the tumor is conforming to the shape of the globe, and it has a variegated appearance with tiny flovoids on MRI. So this suggested it was a cavernous hemangioma, and the treatment of choice for such cases would be a lateral orbitotomy with bone wall removal, since it was more than 3 centimeters in size. We did a bone wall removal. We excised the tumor in toto, And this is her follow-up, where her vision improved to 6/60, but she was left with residual ptosis and enophthalmos. She underwent a ptosis and squint correction later on. A similar case, but a young lady now presents with proptosis since only 3 months, similar vision, but here she had a hyperemic disc with choroidal folds. Here we can see again a well-defined tumor, but it is compressing the globe here, which is causing the choroidal folds, and there are large dilated vessels within the substance. These usually turn out to be malignant tumors. We again went ahead with orbitotomy, and we had to do a piecemeal removal of the tumor since it was encasing the optic nerve, and it turned out to be a solitary fibrous tumor, low grade. And this is her follow-up at 12 months, where a complete excision was curative and no adjuvant radiotherapy was needed. And her vision improved to 6/9 since the disc was not atrophic by this point. Some residual exotropia was noted. Now, a second profile of cases are medial canthal masses. So, a middle-aged man swelling below medial canthus since around 10 years and a failed DCR since 4 years. And on imaging, we can see a well-defined mass with intact bony orbit, slight excavation in the lacrimal sac fossa. And when we opened him up, it turned out to be a soft mass, a mucocele, which had invaded into the orbit. And a simple mucocele excision with a re-DCR surgery gave him enough relief. And this is the patient at 12 months. He has a defect in the inferomedial orbit, but his watering is relieved. There is no residual mass left. And a similar patient, but swelling below the medial canthus since just 4 months. He underwent a DCR surgery, assuming it to be an acute dacryocystitis, which failed. And here we can see the globe is pushed out and up, with the patient almost unable to open the eye. On imaging, we see a large mass in the lacrimal sac area with compression of the globe. Since this mass was also invading into the nasal cavity, as we can see here, and the nasolacrimal duct, the patient went for neoadjuvant chemotherapy with radiotherapy. And after 3 cycles, we can see the reduction in size. An incision biopsy had confirmed poorly differentiated squamous cell carcinoma. We went ahead with 3 cycles of neoadjuvant chemo and radio, and we can see a gross reduction in tumor volume. And the invasion in the nasal cavity was gone, making it a resectable tumor. So the patient went with me and my ENT surgeon. We went ahead with an excision with a medial maxillectomy, and this was the excised tumor. And finally, the patient is on adjuvant radiotherapy. In our final case, we have a middle-aged man with proptosis of the left eye since 8 months. He was diagnosed previously as NSOID, non-specific orbital inflammation, given 3 months of steroids, no improvement. Now currently, his vision is 6/6. We can see a large, well-demarcated lesion in the orbit on the lateral side. What was characteristic is calcifications within this tumor. And in the second image here, which is a contrast image, we can see diffuse contrast enhancement in the tumor. So this suggested a neoplastic mass. The patient was given an option of an incision versus excision, and the patient opted for a total excision. So superolateral orbitotomy was done without bone removal for complete excision with cryo-assisted delivery. And histopath showed an adenoid cystic carcinoma. And the patient was further referred for adjuvant chemo and radio. And this is the patient's follow-up at 6 months, where we can see that the tumor mass has resolved. There is some fibrotic changes left in the left orbit, as seen here in the MRI. And the globe, again, both globes are in the same position. So the proptosis has also resolved. So these were some of my wins, but then we do have some losses as well. A very brief case, an 11-year-old who came with proptosis since 4 months, and the patient had undergone previous 2 biopsies where the histopath showed chronic inflammatory tissue, and the patient was left on steroids. And here we can see a huge tumor which has eroded the orbit, the ethmoid, the frontal sinuses, and also it is eroding the cribriform plate and entering into the anterior cranial fossa. A biopsy revealed it to be a rhabdomyosarcoma. The patient was referred for chemotherapy, but unfortunately we could not save the patient due to an advanced disease. So thank you. My take-home message would be biopsy them as early as possible instead of giving steroids.
Thank you, Dr. Shalin. Please collect your faculty certificate from here. Thank you, sir. We again welcome Dr. Hunawas, sir.
Sorry for the technical problem. I'll be speaking about plaque brachytherapy for ocular surface tumors. If you look at the literature, ocular surface tumors, of course, are very easy to surgically excise. They are straightforward, but they have a huge recurrence, 25 to 40% recurrence, which is simply not acceptable in the situation of a malignant tumor. Malignant tumors can ultimately be life-threatening, and we cannot expect such kind of local tumor recurrences. Every recurrence adds to the metastatic potential of the tumor, and there is, of course, with multiple recurrences, concern for vision and eye salvage. The oncological principles in the management of ocular surface tumors, the principle is edge and base clearance and histopathology guided adjuvant therapy. I'm going to address these two factors. Edge is very easy to determine. You are seeing on slit lamp high resolution image of the patient, and you see that this is the edge of the tumor. Of course, some may say that this is the edge, but you should not miss the thickened conjunctiva around the tumor. And you stain the tumor with rose bengal, and you can now know that even the corneal epithelium to that extent is involved. So we are very clear about the edge. Go all 4 millimeter around the tumor and you're done with the edge. That is how you excise the tumor. But what about the base? Base is opaque to you. You cannot see the base on slit lamp evaluation. How can you see the base? You can only judge the base by trying to move the tumor on the episcleral surface. If it moves, you think that it is not involving the episclera, but you cannot really see it. But fortunately, imaging by OCT and UBM can tell you about the base unless the tumor is so densely infiltrated with keratin, then you have shadowing artifacts. Otherwise, you can actually see that this is the tumor, this bubbly layer is the tenons, and this is the sclera. Very clear. How does it help you? In ocular surface squamous neoplasia, when it involves corneal stroma, if you don't know the depth of the tumor, how will you be able to treat it? This particular tumor has involved the entire thickness of the stroma. You can see splaying of the stroma with high internal reflectivity, indicating that the stroma is full thickness involved, whereas this is normal corneal stroma. So in such a situation, how do you treat it unless you do penetrating keratoplasty or a plaque brachytherapy? Simple superficial excision is not going to help you. Fortunately, imaging correlates with histopathology. This is a study that we did as part of one of our theses, where we find that what you see on imaging is 100% correlatable with what you see on histopathology. So now we have an imaging pathology correlation, and that you can use in the management of OSSN. Surgery with edge clearance is straightforward. It gives you good results. But what if sclera and cornea are involved, or there is limited intraocular extension, and you have excised the tumor, you are sent it to the pathologist, and the pathologist tells you that the base of the tumor is positive? What are you going to do? These are clearly beyond straightforward surgery. Earlier, we would do either extended enucleation or orbital exentration. Just 5-10 years ago, all these patients who had scleral invasion would suffer removal of the eye or exentration. No longer so, because we use plaque brachytherapy in them. What we use is ruthenium. This is an example of a primary plaque brachytherapy. Patient's other eye has poor vision. Patient has had a pediatric ocular injury. He has atrophic bulbi. There's the only seeing eye, and unfortunately he has HIV positive status also and has developed this tumor. This has melted the cornea. Sclera is tectonically unstable. You cannot excise it without creating a gaping hole in the sclera, which you cannot repair. So how do you manage it? We do a safe biopsy from one of the tectonically clear zones of the tumor, confirm the diagnosis, then apply plaque right on top of the tumor. This is called primary plaque brachytherapy. We take the help of either a biopsy or clinical diagnosis, and then directly measure the tumor, tumor height, basal extension, then you do dosimetry to evaluate how much of the dose is required. Then you excise the tumor. This is a similar situation where there is a scleral adhesion where primary plaque brachytherapy is being performed. You can see we are going all around the area of scleral invasion. This patient had lateral rectus invasion as well. So you carefully excise the tumor using radiofrequency electrode that helps you get hemostasis. Most of the surgery can be performed under local anesthesia. You can see the lateral rectus. We already know on MRI that 3 millimeter of the lateral rectus is involved, that we are excising and we are suturing the lateral rectus back later. That's the lateral rectus insertion being excised, and the stay sutures are already passed. Now the lateral rectus is released. Then further dissection is flush with the sclera. It does not involve lamellar sclerectomy. It is in flush with the sclera because we are very sure that we can take care of the scleral component by brachytherapy. Now the residual tumor is treated with plaque brachytherapy. So the base of the tumor is treated with rotational plaque brachytherapy. The plaque has a size limitation. It's 20 millimeter in horizontal diameter, 16 millimeter in vertical diameter. So we use it by rotation. We have treated one part of the base now, and after a few hours, once the dosimetry application is complete, we remove the plaque and put it to cover the rest of the base. So the process continues until the entire base is treated. In this patient, there were 3 rotations required, and after that, of course, we repair the ocular surface with the amniotic membrane. In primary plaque brachytherapy, this is the kind of results you can expect, where the tumor was directly treated with 3D conformal dosimetry. Similar situation. Secondary plaque brachytherapy, when you have excised the tumor and the pathologist tells you that the base is positive, where if the resection base is positive and if it is diffused by protocol, you are supposed to use plaque brachytherapy. This is a situation where the scleral base, say, was secondarily treated with plaque brachytherapy. 6 years postoperatively, sclera is very healthy, avascular, but absolutely tectonically stable and healthy. Similar patient 5 years later, similar patient 4 years later. In conjunctival melanoma, which is diffuse, this patient was from Kashmir and he had multiple prior surgeries with lamellar sclerectomy done locally. Unfortunately, his tumor was all diffuse and he had ciliary body involvement, which you can clearly see on UBM. But he was very keen on eye salvage. He was reluctant to even a suggestion to orbital exentration. Again, I skipped the video, but basically exactly the same thing that we did here. We excised the tumor, flush with the sclera, and for the scleral component, we treated him with brachytherapy, and 4 years later, he does well. This is a similar patient where there was a nodular melanoma with scleral extension, again treated with brachytherapy. So brachytherapy gives about 90% success, which is reasonable compared to 100% enucleation in such situations just 5 years ago. Complications are, of course, that limbal stem cell deficiency is a problem, which we are currently taking care of by doing a primary simple limbal epithelial transplantation along with our primary excision. The initial results have been published in BJO recently. So any patient with ocular surface squamous neoplasia involving the sclera, extraocular muscles and limited intraocular extension would need multimodal management. Thank you so much.
Thank you, sir. I request you to collect your appreciation certificate. Thank you. Here we conclude the oculoplasty session. Now we'll forward to the next session. Yeah, please.
Message using
Ashish, sir.
using RF cautery destroys histopatho examination, I suppose.
I request Dr. Shalin sir, Ashish sir, and Santosh sir for a group photo, please.
Thodi query. Well, sir. Oh, SH. RF cautery destroys histopatho examination. No? And I had a case of primary conjunctival melanoma operated and then recurrence and all that. So it was a corneal involvement also.
Corneal involvement, intraocular extension, all could be treated with brachytherapy.
False corneal involvement?
It did resolve, I showed you.
The panelists of the next session, Dr. Mohak Shah, Alap Bavishi sir, Dr. Ajay Garg, Dr. Paresh Thakkar, Dr. Sanjay Govil. If anyone
There
is
is
there,
an
please come on.
announcement, huh? बार बार दिन ये है, बार बार. It's a birthday boy Parth Rana.
So, good morning, everyone. Dr. Gaurav sir, Dr. Jignesh is here, Dr. Arvind sir, Arvind Moria sir, please. Dr. Kamlesh sir, if he's here. So we will start our next session, that is sponsored by Mankind. The first talk is from Dr. Arvind Moria sir. Ruby Moist nano silver iron based self preservative technology. Dr. Arvind sir is here. Okay, so we will take his lecture later on. I will request Dr. Jagdeep Kakadia sir to present his talk on eye laser X.
It's a voiced video. Thank you, AGOS. Can you please switch on the voice? Audio, please. Hello, dear friends and colleagues. Today we are very happy to introduce to you Laser X, which is a laser-assisted toric axis marker, which is a great help for toric IOLs or for astigmatic keratotomy, and also for astigmatism control by on-steep axis incision placing in phaco or MSICS surgeries. LaserX is a small slit-lamp-mounted modular device having two powerful laser guns. First, the slit is made horizontal at 0 to 180 degree, and then with the first press of foot switch, very low power aiming lasers come on, and then the slit is brought to cross the center of the pupil, and then with the second press of the foot pedal, two powerful flash shots will create two linear burns marks on test paper. After numbing the conjunctiva with proparacaine eye drops, the patient is taken on slit lamp and the head is best aligned. With the other eye closed, the patient is asked to fixate on this central red target light, which also gives a red Purkinje 1 image on cornea, denoting actual and real the position of visual axis in the pupillary area of cornea. After bringing the horizontal slit in the corneal center, such that it passes through or just under the red dot Purkinje image, the laser shot is fired and two marks are done on cornea in microseconds. This is how laser X marks look on table. Marks remain as is, varies throughout the surgery, and they stay also afterwards for many hours. Laser X marks stay as is for about 12 hours, so we can do marking in advance few hours before or just few minutes before the surgery. One more case. Same case on table. Please notice the clockwise 20-degree cycle rotation on table in supine position. Many surgeons prefer to do marking on the limbus, in which case marks look like this. By putting few drops of trypan blue dye or just a touch with GV marker pen, we can highlight and enhance marks like this. It is also a good method to do laser markings before dilating the pupil, keeping the slit horizontal and passing the slit through the center of the small photopic pupil. In this way, it is easier to align at 3 and 9 o'clock position. This 405 nanometer 5 watt near UV visible deep blue laser is completely and only absorbed by the corneal epithelium. These marks, they last for about 8 to 10 hours and they don't cause any pain or foreign body sensation in post-op period. Marks are only superficial, just the epithelial. They are painless and they disappear in less than 24 hours without any scarring. Intraoperative secondary marking with or without ink just by the pressure of desired axis can be done by Gimbel-Mendes ring or R.C. Shah toric marker. So for those of us who cannot afford the very high cost digital image guided toric marking systems, much less expensive LaserX is a good and equally effective and equally accurate alternative. LaserX module can also adapt a 4K video camera, so it can also convert the same slit lamp into a video or photo slit lamp. Recently, we have also converted one old Jowl Shears keratometer into LaserX, in which the laser guns are housed in these two tiny boxes and the whole laser bar can be pre-rotated to directly mark the desired axis on cornea or limbus, so we don't need to do secondary markings on table. Thank you very much for your kind attention. Thank you.
Excellent, sir. You come with every time new invention and teach us more, and it makes you makes ophthalmologist life very much easy and stress free, because pre-operative marking is very much stressful. Sometimes patients are not cooperative. Sometimes we cannot get proper 360-degree marking. The 080 degree, 180 degree is not also aligned. So there may be some error while putting the toric IOL in the proper desired axis. So it is a great innovation. I request Dr. Gaurav Mehta to present a certificate. Dr. Kakadia, sir. The next talk will be by Dr. Arvind Moria, sir. That is Lubrimoist, a nano silver ion-based self-preservative technology. I request Dr. Nutan Madam to keep her lecture ready. That is NABH accreditation.
Very good morning, esteemed chairpersons and my dear friends. So my talk is on a novel nano silver ion based self-preservative technology. So there are a lot of preservatives in eye preparations like the quaternary ammonium detergents, the oxidizing agents, the ionic buffers are there, then there are amidines, then there are parabens, then there are alcohols, and some are mercury based also like thimerosal. So why these preservatives are not so good for the dry eye patients? Because it has detrimental effects on the ocular surface and leading to the disorders and toxic also. So we need this preservative free eye drops. So when to opt for these preservative free eye drops? when there is the presence of moderate to severe dry eye, glaucoma, the patients who are on contact lenses, serious eye allergies, and when there is digital vision syndrome. So silver is widely known for its biocidal properties. It exhibits bactericidal, fungicidal, as well as virucidal properties. And this biological efficiency of silver nanoions is higher because of the high surface to volume ratio. And this technology, so the nanosilver ion based antimicrobial technology is there. So this nanosilver ion based antimicrobial powder is mixed in ophthalmic bottle, nozzle and caps, which inhibits and destroys the growth of bacteria, fungi, and the other organisms. And the features of this nano ion based technology is the wide spectrum of the antimicrobial activity. So how it acts? So it disrupts the cell wall and the membrane by this effect, and it disrupts the membrane by reactive oxygen species and denature the membrane, and it also perforate the membrane by the silver nitrate action. So this microbiological studies are being done to prove the antimicrobial activity. So this definition is known as the antimicrobial efficacy testing to demonstrate the antimicrobial efficacy of the Lubimoist eye drops, and the microbial in-use study to evaluate the efficacy of this Lubimoist eye drop. So there are different acceptance criteria for the ophthalmic solution as per the US pharmacopoeia as well as the Indian pharmacopoeia. So there are limits for the ophthalmic solution products. So for the bactericidal, not less than 1 log reduction from the initial calculated count at 7 days, and not less than 3 log reduction from the initial count at 14 days, and no increase from the 14-day count at 28 days. And for yeast and molds, no increase from the initial calculated count at the 1, 2 and the 4 week time. So for the log reduction, 1 log reduction, percentage is 90% decrease in the microbial growth, and 3 log reduction up to 99.9% decrease in the microbial growth as per this study. So the various microorganisms used during the studies were Candida, Aspergillus, E. coli, Pseudomonas, as well as Staphylococcus. So this is the brief methodology. So it was mixed, the silver nanoion along with the sodium aluminate eye drop, and the microorganism, as we have already discussed, E. coli, Staphylococcus, Pseudomonas, the Candida, as well as the Aspergillus. The log reduction was observed 1.3, 1.7, 1.9 and up to 2.1. And after 2 weeks, it was again increased to 3.6, 3.1, 3.5, 3.2 and 3.2. So the acceptance criteria for 7 days is 1 log reduction, whereas the acceptance criteria for 2 weeks is 3 log reduction. So with this silver nano ion technology, it was much higher than the accepted level. Again, at log reduction at the 7 days as well as after 2 weeks, the acceptance criteria is again 1 and 3 log reduction. That is again much higher was observed. So in summary, 1 or more than 1 log reduction at 1 week and 3 log reduction at the 2 week duration. So to combat any microorganism during use of the Lubimoist eye drop. So this efficacy of Lubimoist eye drop with nano silver ion based self-representative technology meets the acceptance criteria, and it was divided in 2 parts. So in-use whole time study as well as in-use microbial challenge study. So during the study, after conducting initial bioburden, the product was kept at room temperature and product was exposed to air thrice a day by opening the cap and nozzle, and bioburden was again checked at different time points, that is 10 days, 30 days and after 2 months. And in the other subset, one set of sample was spiked with 3 strains of microorganism, about 1000 colony forming unit per ml, and 2 were the bacterial strains, E. coli as well as Pseudomonas, and 1 fungi strain, that is Candida, and bioburden was again checked at some same time point, that is 10 days, 30 days and after 2 months. So the observation for the in-use study, So there was, after 10 days of colony forming unit, it was nil. After 1 month, again nil. And after 2 months, there was nil growth of all these dreaded microorganisms. So there are two types of toxicology studies. One is a systemic injection test in the Swiss albino mice, and other one was done in the intracutaneous reactivity test in New Zealand in the white rabbits. And both these studies have been passed, and there was no any local irritation or abnormalities observed. So this is the eye drop, and this is a small video.
Welcome to the world of preservative-free. Mankind's introduces patented self-preservative technology, which is based upon silver nanoions that favors better ocular well-being for patients. Nanosilver ions have scientifically proven biocidal property, and it exhibits bactericidal, fungicidal, and virucidal properties. When Lubamoist preservative-free eye drops has been exposed to air, it was sterile up to 60 days. Lubamoist preservative-free eye drops offers broad-spectrum efficacy against microbes, cost-effective and patient-centric bottle, no leachable impurities. Self-preservative Lubamoist eye drops.
So thank you so very much for the opportunity. Thank you.
Thank you so much, sir. I would request Dr. Nutan to come on the stage to present NABH accreditation. The next speaker is Dr. Narendra Singh Verma, sir. Please ready with your talk, sir.
Morning, esteemed chairpersons and my dear friends. So my talk is on a novel nanosilver ion based self-preservative technology. So there are a lot of preservatives in eye preparations like the quaternary ammonium detergents, the oxidizing agents, the ionic buffers are there, then there are amidines, then there are parabens, then there are alcohols, and some are mercury based also like thimerosal. So why these preservatives are not so good for the dry eye patients? So because it has detrimental effects on the ocular surface and leading to the disorders and toxic also. So we need this preservative-free eye drops. So when to opt for these preservative-free eye drops? When there is the presence of moderate to severe dry eye, glaucoma, the patients who are on contact lenses, serious eye allergies, and when there is digital vision syndrome. So silver is widely known for its biocidal properties. It exhibits bactericidal, fungicidal as well as virucidal properties, and this biological efficiency of silver nanoions is higher because of the high surface to volume ratio. And this technology, so the nanosilver ion based antimicrobial technology is there. So this nanosilver ion based antimicrobial powder is mixed in ophthalmic bottle, nozzle and caps, which inhibits and destroys the growth of bacteria, fungi and the other organisms. And the features of this nano ion based technology is the wide spectrum of the antimicrobial activity. So how it acts? So it disrupts the cell wall and the membrane by this effect, and it disrupts the membrane by reactive oxygen species and denature the membrane, and it also perforate the membrane by the silver nitrate action. So this microbiological studies are being done to prove the antimicrobial activity. So this definition is known as the antimicrobial efficacy testing to demonstrate the antimicrobial efficacy of the Lubimoist eye drops, and the microbial in use study to evaluate the efficacy of this Lubimoist eye drop. So there are different acceptance criteria for the ophthalmic solution as per the US pharmacopoeia as well as the Indian pharmacopoeia. So there are limits for the ophthalmic solution products. So for the bactericidal, not less than 1 log reduction from the initial calculated count at 7 days, and not less than 3 log reduction from the initial count at 14 days, and no increase from the 14-day count at 28 days. And for yeast and molds, no increase from the initial calculated count at the 1, 2 and the 4 week time. So for the log reduction, 1 log reduction, the percentage is 90% decrease in the microbial growth, and 3 log reduction up to 99.9% decrease in the microbial growth as per this study. So the various microorganisms used during these studies were Candida, Aspergillus, E. coli, Pseudomonas as well as Staphylococcus. So this is the brief methodology. So it was mixed, the silver nanoion along with the sodium aluminate eye drop, and the microorganism, as we have already discussed, E. coli, Staphylococcus, Pseudomonas, the Candida as well as the Aspergillus. So log reduction was observed 1.3, 1.7, 1.9 and up to 2.1. And after 2 weeks it was again increased to 3.6, 3.1, 3.5, 3.2 and 3.2. So the acceptance criteria for 7 days is 1 log reduction, whereas the acceptance criteria for 2 weeks is 3 log reduction. So with this silver nano ion technology, it was much higher than the accepted level. Again, at log reduction at the 7 days as well as after 2 weeks, the acceptance criteria is again 1 and 3 log reduction. That is again much higher was observed. So in summary, 1 or more than 1 log reduction at 1 week and 3 log reduction at the 2 week duration. So to combat any microorganism during use of the Lubimoist eye drop. So this efficacy of Lubimoist eye drop with nanosilver ion based self-preservative technology meets the acceptance criteria. And it was divided in 2 parts. So in-use whole time study as well as in-use microbial challenge study. So during the study, after conducting initial bioburden, the product was kept at room temperature and product was exposed to air thrice a day by opening the cap and nozzle, and bioburden was again checked at different time points, that is 10 days, 30 days and after 2 months. And in the other subset, one set of sample was spiked with 3 strains of microorganism, about 1000 colony forming unit per ml, and 2 were the bacterial strains, E. coli as well as Pseudomonas, and 1 fungi strain, that is Candida, and bioburden was again checked at some same time point, that is 10 days, 30 days, and after 2 months. So the observation for the in-use study, so there was after 10 days of colony forming unit, it was nil. After 1 month, again nil, and after 2 months, there was nil growth of all these dreaded microorganisms. So there are 2 types of toxicology studies. One is a systemic injection test in the Swiss albino mice, and other one was done in the intracutaneous reactivity test in New Zealand in the white rabbits. And both these studies have been passed, and there was no any local irritation or abnormalities observed. So this is the eye drop, and this is a small video.
Welcome to the world of preservative-free. Mankind's introduces patented self-preservative technology, which is based upon silver nanoions that favors better ocular well-being for patients. Nanosilver ions have scientifically proven biocidal property, and it exhibits bactericidal, fungicidal, and virucidal properties. When Lubamoist preservative-free eye drops has been exposed to air, it was sterile up to 60 days. Lubamoist preservative-free eye drops offers broad-spectrum efficacy against microbes, cost-effective and patient-centric bottle, no leachable impurities. Self-preservative Lubamoist eye drops.
So thank you so very much for the opportunity. Thank you.
Thank you so much, sir. I would request Dr. Nutan to come on the stage to present NABH accreditation. The next speaker is Dr. Narendra Singh Verma, sir. Please ready with your talk, sir.
Good morning, and thank you for your giving me the opportunity. Basically, seems to be a compelling talk between the great sessions that are going on. But I think somewhere we have to start thinking for the quality and safety. So the topic actually is NABH accreditation, but since years it has always been a debatable thing. Most of us feel we should not really enter into it because we have been practicing for so many years without that, and we never had problems. So what we'll discuss is NABH or no NABH. QCI definitely matters because we all are concerned about the quality. So quality control implementation is this QCI, and Quality Council of India is what is really guiding us with certain protocols. So at every stage or step of our life in ophthalmology, we see to it that our medical and surgical management, we try to give the best of it to get the best results at a particular setup. And each and every time we want to get it, and we want to have consistency if we can't improve better, more than that. I'm not going to talk on these 10 topics, I mean the standards chapters, which are actually done so very well by ECO book, and AIS has really worked very hard since so many years. It's almost spoon-feeding us with all the standards and objectives of the 10 chapters. 5 being patient-centered, 5 being organization-centered. And most of the other specialities and assessors feel that ophthalmology as a speciality is blessed with having specifically oriented standards. And thanks to the AIS hardworking and the team that has been working for it. And they have been improving, they have been trying to remove the gray zones, which are still debatable. So ultimately, we are coming back to quality and safety, which are always two important concerns from our point of view also and from patient's point of view. And actually, these are the ones which are given maximum importance even in NABH accreditation or by assessors. Quality control in our journey of practice, we always have to give these questions to ourselves and to our team. Why we have to do, how we will do, when we will do, and if we get even a small answer for it, try to implement. Make the whole team work for it, then only we will be able to see the results. So because quality always matters. This is most important that we have to teach to our team as far as quality is concerned, that it means we are doing right as per our protocols even when no one is looking. And when no one is looking means that's why we'll have to have some validation, some scrutiny, just as we have CCTVs, we have indicators, something which will prove that yes, the quality is being maintained or the protocol is being maintained. I'll give some few examples only of each chapter, and the first and most important, of course, to all of us is hospital infection, HIC chapter 5, and OT cleaning is something which probably most of us are not looking into it. Not that personally we look into it, but at least set up a protocol, designate a person that you have to see that all these things are done, and if the cleaning is not proper, whatever AHUs we have, whatever type of OT we have, will not be a sterile OT. So it's very important that we have laid protocols. It can be in vernac language also. And again, I'll stress that we always run after our own surgery, how to improve on it. But these are not the only factors which decide the ultimate outcome. These small things need to be looked into. Similarly, why do we need to do cultures? Again, it's a validation. Whatever way we are cleaning our OT, keeping it clean, is it okay? The second most important part was patient safety. Medico-legally, now we know that we are not in a situation, the practice is not as it was like when we started 40 years back. This was probably not even thought about. Now it's not at all like that. And unless we look into these matters, I think we'll all be asking Dr. Lane to please help us. Now we are stuck up somewhere. So it's better that we have some preventive measures already, like in infrastructure. These are very small points, sometimes not even thought of. But the day we have a fall in the staircase, there are only 3 or 4 steps, suppose. Even there, why not a sidebar? So these guidelines are actually fed to us, a very good spoon feeding, almost I think Riles tube feeding by AIS book on NABH accreditation. Same way SSCL, I have as an assessor wherever I've gone, there are so many people who feel that why we should fill up this form. It is going to be the only savior. Like if you have a record that every time SSCL has been recorded, it will be a savior if someday something goes wrong and you have operated a wrong guy or a wrong patient or whatever. So such a checklist is of the utmost importance. Similarly, our UPS, fire safety, these are just examples. You can go into the book, get into the details, find out something that really appeals to you and you have no debate in your mind, and start implementing in some way or the other. I'll give an example of each chapter, only one example. Suppose we take chapter 1. It says all vulnerable cases should get a priority. And we know, yeah, they should get priority. Before one patient starts having some problem in our OPD, why not do it? Similarly, COP is the second chapter. Simple. When the drops are to be put, there should be no touching. So the first day of our staff also would know that this is how it has to be done. This is the induction training that is called. And then we will not be afraid, though, aaj roz ka staff to nahi, ab kya hoga? Kuch nahi hoga. This is something very important which I have learned during these assessments. In our OT, we can keep something like a code V. So no one really realizes except our team knows that the vitreous has come, what has to be done. There will be a kit for it. And every person, right from, the junior most staff, the washed up staff, the assistant, everyone knows now what all to be got into the OT. Third chapter, MOM. Why LASA? LASA is like sound alike drugs. We want to avoid these errors. Why? We don't want to have pilocarpine instead of adrenaline. That's why. This was long back, but PRE, we can make the patient understand that your mask is so important and it is mandatory. This we have already taken, and believe me, if you want to start something about it, start from HIC. There'll be so many things which will appeal. Yes, we have to do this. Sixth chapter, CQI. KPI is key performance indicator. NABH language itself states, certain things. Why we can't start? You all want to know what is the steep axis incision and how much astigmatism it is given. It is not only for academics that we have to study, we can do it for ourselves. ROM. The budgeting, reorder policy, all these are important. Why? Suddenly it should not come that nurse will say, "Aaj to apne paas hilon nahi hai, aaj to ye nahi hai, aaj to ye TTR nahi hai." It should not happen. FMS. Fire safety is something which none of us can avoid. All the employees need to be taken care. Otherwise, there are certain, legal problems that we can land up into with the labor laws. And this is what is one of the most important take-home message: documentation. Whatever is documented is always considered as done, whether it is done or not. And if it is not documented, nothing can help us. It is considered as just not done. And this is what everywhere is, right from consent to whatever is happening, a patient has collapsed in the OT, whatever happens, unless and until it is properly documented, no one will believe that we have tried to resuscitate the patient. So this is the take-home message. Implement at least certain things, whichever you feel are correct. Start doing it. And these are the methods which are being followed. Like Kaizen is a method. Like you select one event, you assess your own, what is happening at your own hospital, reassess, try to plan and design that now we will do something like this so that we don't do these mistakes. Start implementing, and implementation is from doorman to chairman. Each and every person of the team has to dedicatedly do it. Evaluate whether it is working. And that is where we have to get very disciplined approach, bring about a boost in morale, explain the intent. Each and every standard or objective that is given in the ECO book of NABH has a particular intention. Like so and so size of OT. It is not that they want to see this much OT. The idea is around the 6 by 3 feet of the bed of OT. Whether the patient will be resuscitated. Do you have the place to move around? Leaving behind the surgeon's place, the trolley. In spite of that, there should be a place where everything can be mobilized for a resuscitation. These are the standards, and each and every standard has an intention behind it. So the intent should be clear to each and every person of the team. That is when everyone will start following it. And whatever our suggestions are there in improving at a particular setup, the staff will sometimes have very good suggestions for your own setup. Listen to it, start implementing it. Thank you.
Thank you so much, ma'am. It was a great information. it is now not the era that patients are saying that Dr. Bhagwan hai or Dr. God hai, and they will never accept anything. And the quality what we give, we can generate the revenue more for that also. That is our advantage. And medical legal is one more thing in today's era, that every practitioner, either that is a senior practitioner or a junior practitioner, should learn. So these are the must for your private practice, and it improves your quality and gives quality service to the patients also. Thank you so much, ma'am. Our next speaker is Dr. Narendra Singh Verma, sir. His talk is on toric error analyzer.
So toric error analyzer is easy to use. It is easy to use realignment formula for toric IOL refractive surprise like astigmatismfix.com and Barrett RX formula with some advanced new features. So this is a case of against the rule astigmatism nearly 1 diopter. The recommended IOL was 24 diopter T4 in 3 degree. I implanted 23.5 diopter T4. Post-operatively, there was refractive surprise of 2.25 diopter. So I thought कि भाई लेंस थोड़ा घूम गया है, 3 डिग्री पे डालना था, अब नहीं है तो कोई इसको मैं 3 डिग्री पे रोटेट कर देता हूँ. But when I check the realignment axis on astigmatismfix.com, then I fill all these data. Only 2 data are important, but ये बहुत से data पूछते हैं, बहुत बड़ा form होता है इनका. Then the astigmatismfix.com told me that you have to realign the lens to 168 degree. प्री-ऑपरेटिव एक्सिस थी 3 डिग्री थी, अब वो बोल रहे हैं astigmatismfix.com वाले के 168 पे रोटेट करो. 15 डिग्री का चेंज हो गया. मैंने कहा ऐसा क्यों हुआ भाई, कहाँ प्रॉब्लम हो गई है. Then I thought I will refer the Barrett RX formula. For Barrett RX formula, you have to enter the post-operative biometric data, axial length और ACD. मैंने वो चेक किया, फिर वो सब डेटा डाला. Then Barrett is saying that you have to rotate the lens to 171 degree. Pre-operatively 3 degree पे था, अब 12 degree का difference है. So I rotated the lens to 171 degree. तब तो सिलेंडर था 2.25 था, 0.5 हो गया. So I was happy. But I thought that why there is rotation of 12 degree, 12 to 15 degree. Pre-operatively, axis of alignment was 3. Post-operatively, they are telling that rotate the lens to 171. This is the case 2. With the rule astigmatism, about 5 diopter was there. Recommended IOL was 14 diopter T9 at 101 degree. मैंने सोचा स्टीप एक्सिस पे इंसियल ले लेंगे, T9 नहीं डालना है, T7 डाल देते हैं. ठीक है. पोस्ट ऑपरेटिवली देयर वाज रिफ्रैक्टिव सरप्राइज ऑफ 2 डायोप्टर सिलेंडर. मैं कहा यार गलती हो गई, T9 बोला था, T7 डाल दिया, अब तो लेंस चेंज ही करना पड़ेगा. Then I see the what this formula is telling. तो दोनों फॉर्मूला बोथ Barrett RX and astigmatismfix.com they recommended कि there's no need to change the lens. आपने सही किया, T9 की जगह T7 डाला, बस उसको रोटेट कर दो 97 पे. So I was surprised what happened. So they are telling that in spite of T9 you better to put T7. And in this case also there is rotation of axis by 4 degree. So what we are getting, these realignment formula, ये क्या बताते हैं हमें, सिर्फ एक ही चीज बताते हैं कि अगर आपको रिफ्रैक्टिव सरप्राइज है तो लेंस को आपको कितना रोटेट करना है और उसके बाद कितना रेजुलर रिफ्रैक्शन बचेगा. और व्हाट आर द लिमिटेशंस, दे रिक्वायर्ड मल्टीपल डेटा, बहुत सारा डेटा एंटर करना पड़ता है. देन दे आर अनेबल टू टेल हाउ मच अमाउंट ऑफ रिफ्रैक्टिव सरप्राइज इज कॉज्ड बाय SIA, एरर इन PCA, जो PCA हम मेजर कर रहे हैं, जो वैल्यू या प्रेडिक्टेड की डाल रहे हैं उसमें कुछ डिफरेंस हो सकता है उसकी वजह से. एंड इनएक्यूरेट टॉरिक पावर, जो रिकमेंडेड पावर है वो ज्यादा या कम हो सकती है, उसकी वजह से भी कुछ सरप्राइज आता है. तो दीज फॉर्मूला आर नॉट टेलिंग अस कि व्हाई these other factors, how much these factors are contributing. So toric error analyzer is the first of its kind formula which will provide you realignment axis and residual refraction by 2 methods. First method है which is based on fixed toricity ratio, exactly same जो astigmatismfix.com आपको देता है, बिल्कुल same result आपको देगा. And based on the variable toricity, डिपेंडिंग ऑन द ELP जो बेरेट RX देता है, तो दोनों फॉर्मूला के रिजल्ट आपको एक साथ दे देगा. At the same time, it will tell you how much refractive surprise is due to SIA, PCA, and inaccurate toric power. Let's see how it works. Video कहाँ से चालू होगा?
Enter this URL or scan QR code. Click on Toric Error Analyzer. This data sheet will open. This was previous case of myopia. Enter post-op refraction, toric lens power, and its current axis in the data form of Toric Error Analyzer. The best realignment axis based on the fixed toricity ratio is 98 degrees, which is identical to the results from astigmatismfix.com. Next, enter the axial length, ACD, and A constant. The best realignment axis based on ELP is also 97 degrees, which matches the Barrett RX formula. Enter preoperative and postoperative keratometry, net astigmatism, or TK. The app will display this graph. By rotating the lens from 117 to 97 degrees, the residual refraction decreased from 2 diopters to 0.15 diopters. The SIA was 0.53 diopters. Since the 2.8 mm phaco incision was made on the steep axis, it decreased the postoperative astigmatism by 0.35 diopters, shown in green. The error in PCA was 0.71 diopters, which increased the postoperative astigmatism by 0.39 diopters, shown in red. This resulted in a net decrease of 0.07 diopters in the astigmatism magnitude, shown in green. As a result, post-op toric power of IOL reduced from 4.85 to 4.74 diopter, for 0.74 is closer to 4.5 diopter, so toric power of exchange IOL changes from T9 to T7. The preoperative axis was rotated 2 degrees counterclockwise due to SIA and 5 degrees clockwise due to an error in PCA. The resultant rotation was 4 degrees clockwise, so the new axis was rotated from 101 to 97 degrees. Enter this URL.
What is the advantage of toric error analyzer? It is easy to use. आपको डेटा शीट में सिर्फ कुछ ही डेटा भरना है, and it will provide you realignment axis and residual refraction by two methods. If the refractive surprise due to SIA, वो आपको पता लगा SIA की वजह से है, then you can improve your surgical skill. You take the incision more on the limbal, decrease the size of incision. If the error is due to PCA, if you are measuring the PCA by some, you are measuring the TK, और एक ही टाइप का एरर आ रहा है, एक ही एक्सिस में आ रहा है, then you can calibrate your device कि डिवाइस में कुछ प्रॉब्लम है. You can also compare predicted and measured PCA. इसमें सिर्फ लास्ट में आपको नेट एस्टिमेट की जगह अगर आप टीके डालेंगे तो मेजर्ड PCA क्या एरर बताएगा कितना हो रहा है उसकी वजह से, और प्रिडिक्टेड डालेंगे नेट डालेंगे तो प्रिडिक्टेड का बताएगा. सो एट द सेम टाइम यू कैन एनालाइज दैट whether predicted is better or measured is better. And one more thing is that if so, this is the graph. This graph will provide you कि pre-operative lens की power कितनी थी. In that myopic case, it was 4.85. It was decreased to 4.74 due to the SIA. SIA has, which was incision was on the steep axis, so SIA has decreased the astigmatism. So this, how much was the power pre-operatively and post-operatively? This is the extra features which we are providing. Thank you.
Thank you so much, sir. It was a nice information. So we will look for that, and if any error occurs after the toric, we will surely try this next time. I would like to request Arvind sir to present certificate to Narendra sir. There is one announcement. Everyone is requested to check out their rooms because we have to hand over the rooms to the resort. I would request Dr. Lane sir to present his next talk on phaco in white cataract.
Good morning, everybody. Thank you again, Jagdish and team. Now, my topic today is white cataract. The challenges are absence of the fundal glove, so that can be tackled with the trypan blue. And when we are using this trypan blue, we inject and then we wash. That never helps. So when you are using it for the mature cataract, it should be minimum 65 seconds inside the anterior chamber. That will definitely prevent it from the tearing. So put it for one minute. Then the rexis, you can use a forceps. Then the anterior vitrectomy or 3-piece IOL. Let's drop to the vitreous surgeon. Endothelial damage, you will have to use the visco. So we never use the visco when we start the phacoemulsification and decentration. You can just rotate or change. Now this is the case first. See, there is a fibrosis in the center, and then when there is a fibrosis, suggests that, see here, whenever you are, can you see, making the opening, it should be in the mid periphery. Don't open in the center, because the fluid is more in the center. So it is always better to open in the mid periphery, where the pressure of the inside fluid is less. So now again I am using the forceps, and once I am using the forceps, so it will be, you can say, you can control the rexis. But if there is a fibrosis, there also you can't control the rexis. See here, I am doing it to the forceps, but still it has gone beyond, because that was the fibrous area. So the rexis is bad, and now you see the lens has just, can say, vertical. So here you can do the, can you see, this is a, you can go for the horizontal chop. So periphery, you can see the chopper is blunt tip chopper, and then you are burying the tip in the center, and then the horizontally you are chopping it. But here the two equipment, that is the instrument, you could tip and the chopper, they should work in harmony. Again you will see here, and then you can just chop it, the horizontal chopping. Again, as there is no buttress, it moves. It is a, here when it is the last piece, the minimal chopper, just chopper will be there for the stabilizing the piece, and then gradually you will remove this. So in the last piece you will have to go slow, but here what we do, we go fast. Now this is the case 2. See here, you can see the fluid inside. So when there is a fluid inside, then again you should take more precautions. So after the staining, and you see here, I am just going, the opening is curvilinear, so that it will not extend. Doing it with the needle now, but it is go gradually, and then do slightly larger rexis. You can see the fluid coming, and after this I use the forceps, slightly decenter rexis, fluid is removed, and now you can see the cataract here, it is a slightly brown. So when it is a brown, then again I am using the sharp chopper. You will see buried inside the lens substance, lens tip is slightly down, and when it is, see here again, unless and until it is buried properly, this will not break, and then I will make pieces. So that is also the center of the lens. Again you will see here. So whenever there is no any support to the lens, the lens rotates. So you will have to catch hold the lens by your two instruments, by the phaco tip and the chopper. Again you will see the chopper is buried inside. Again it is the slipped. So that happens when there is a such type of hypermature cataract is there. So again the cautions you will have to take. Again I am separating it, and the buried the tip inside, and once that is there, then the piece is made. So here you will not get the uniform pieces, but yes, you can do it, and the phaco is possible in these cases. Only thing is that chopping you can do when you have got the experience. So that is what is important. So here see it is completed, the phaco, and then and see this is the white cataract. But if you see this cataract, this is not an hard cataract. This is though it is very white and mature cataract. See the fluid is coming out. It is an intumescent cataract. And again you can see I am aspirating the fluid, and then by forceps I am doing the rhexis. See, here again the rhexis is done, and this is a soft one. So it is as it is a intumescent, the soft cataract. You can see the color of the cataract, and here it is white, not you can say brown or yellowish cataract. You can see here I am using the horizontal chopping. Again this up to the center you will have to chop. Again you will see the chop I am doing here. Again so different types of cataracts chopping. So this is a soft cataract, but intumescent one. So the pieces are easy, but sometimes in such cases you may have the piece tear. So always better to go very slow and then complete the case. So as it is soft, we should not just jump and do it fast. Always better to go slow. Another cataract, as you can see, this is a hypermature cataract, and I am trying to do can you see where I am wrong? In the center, I have opened in the center. This is to show this one, and now I am taking the forceps as it was not properly going, and once I am taking, and then you can see the Argentinian flap. So this has happened because opening was done in the center. So always opening should be in the mid periphery. So now I am just changing it. You can say I have changed and then doing the phaco. Now see the flap near my phaco tip. That flap is moving. That is flap motility sign. Now if that flap is moving, then your tear is not extended to the posterior capsule. This is by the Rohit Om Prakash, flap motility sign. And if that flap is not moving, stop your phaco there only, because now you have entered in the posterior capsule. So whenever you are doing the phaco, you will have to always keep watch on the flap motility sign. And if that flap is moving, it means you can do phacoemulsification because your extension has not gone posteriorly. So this flap motility sign always helps us for this. Now this is the another this one. I am doing the phacoemulsification. You can see the tip. The tip is here. You can see is a transparent sleeve, and I am trying, but it is not penetrating. So it is because of the stroke length of the machine. The machine stroke length is not much more, and because of that, the penetration is not happening. And as I am doing it, so after that also you will see the lens is moving, and it is not at all the penetration is happening. So I am trying, but the lens is moving only. So you can see now this is rotating, and here you can see your heart also rotate like that. You get flutter. It means there is a pressure on your heart also. Can you see this is rotating? So this is because of the lens, this phacoemulsification machine. Can you see this? And you can see the transparent sleeve there. So lastly, I thought that it is not going to enter inside, and then see here, gradually if I am giving any pressure, only the lens is moving and it is not penetrating inside at all by any means, support, horizontal, vertical. So I removed it, and then you will see it is a white, and then I can do it. It is just a stroke length. Because of that it was possible. So the die for the capsular stain, sharp tip and chopper, chop and chop technique, effective use of ultrasound, and what is effective in your hand, you choose it. You can see anything, but do what you can do. Thank you very much. And thank you for everybody, Gujarat Ophthalmic Society, for inviting me. Thank you very much.
Thank you so much, Lane sir, for sparing your valuable time with us and sharing the tips and tricks. These are really hard cataract, and always these cases are every time new for us. Whenever we start the surgery of wide mature cataract, we have to be prepared, and we have to be ready for any complications. Our next talk will be Dr. Ragini ma'am on soft cataract phaco.
Thank you, Bhavik Bhai. Respected Dr. Jagdish Bhai Rana sir, my teacher Padma Shri Dr. Lahane sir, my brother Santosh, all the managing committee members, everybody on the dais, senior teachers, Dr. Nutan Shah ma'am, and everybody who worked hard to make this conference a success. So it didn't rain last night. It rained today morning just to make us all pleasant, and once the session started, it stopped raining again. So that's the beauty of working hard. Soft cataract or polar cataract. So you saw sir presenting hard cataracts, and I used to cheat on the next table and steal all his soft cataracts thinking they were very easy. So let's discuss this. I have no financial interest. So what is difficult in a soft cataract is that there is no grip of the nucleus. The nucleus is so soft that even if you try to pass a dialer through it, it will go through and through the nucleus many a times. So the standard techniques that you use of stop and chop may not work, and it's very difficult to chop some of the few soft nuclei. Because the nucleus is so soft, your fluidics may be affected and they may be surge. And in case of posterior polar cataracts, which are very common nowadays with people using lots of steroids and steroids, under false pretenses, so there will be an unstable posterior capsule. So there are various techniques. There are all phaco surgeons over here. So whatever you do and whatever is safe in your hands should be done. But a small rexis, because here, in large nuclei, you want the rexis to be big. Previously, we used to make small rexis in these cases because then we would put a lens on the anterior capsule or a sulcus fixated lens, but now there are many options available. We do not know what is there in the posterior pole, so always a hydrodissection free phaco, only hydrodelineation. Low vacuum, because the nucleus is so soft, you really do not need too much of ultrasonic energy to emulsify the nucleus. So the parameters like vacuum and inflow and aspiration are very, very low. In cases where you are worried that the fluid may cause a PC, small attenuation to enlarge or be converted into a defect, dry aspiration also works for the cortex and epinucleus. So these are some important points. Now, what are the signs of caution? If there is a thick central plaque surrounding a central zone of attenuation, so one has to be careful. There may be thick opacification in the periphery of a central dehiscence. There may be a peripheral thin opacification and mottling, which suggests an intact capsule, onion peel appearance, and lots of things. In spite of doing a very good slit lamp examination, there will be surprises on the table. So one has to be prepared for a posterior segment standby and availability of standby lenses and vitrectomy and everything. So these things are very, very important to note. These cataracts, because they are attenuated, may invite capsular rupture more often than other cataracts. That will be the difficulty. There may be a frank defect or there may be an abnormal attenuation. So what is important is, the best thing is that the pupils dilate well, the glow is good, and a small rexis. In whatever type of cataract surgery I do, I always use multi-point hydro procedure because that is much, much safer. And here, like, you start by emulsifying the cortex, and then now in these cases it depends on how soft or hard the nucleus is. This nucleus is grade 1 or 2, and then you can stop and chop it. So here it becomes very easy because the patient is a little bit of older age, and you can see that the nucleus, though it was looking soft, it is a grade 1 to 2 nucleus and a proper divide and chop. So the first division, the second division, and now emulsifying the nucleus is very, very easy. So this is a standard case where everything goes well. This is the type of a cataract which is best for beginners or somebody who wants to do more phaco cases, where this is a standard case. But does it happen all the time? No, it may not be the case every time. So here you see that the cataract is very, very soft and it was not possible to do anything. So the nucleus is lifted slightly. You try to emulsify it. Instead of the chopper, we are now using a dialer. The nucleus is lifted completely or flipped. This is the nucleus solute. And in phaco mode 2, it is emulsified completely. Now, trying to chop this nucleus would not have worked. Because of the hydrodelineation, we see a large epinucleus, which can then be emulsified in the epinuclear mode. This is a classical posterior polar cataract. One has to be very careful and do only hydrodelineation, as you can see over here. And then you try to emulsify it. I have even gone and done hydro after finding that the nucleus is not rotating. Now here it is possible to do a trench and the first division. So this nucleus is slightly manageable to a stop and chop technique and malleable to it, so it's okay to do it. So at any given time on the table, one has to decide, because it's only the feel of the nucleus after you go in which tells you whether you will be able to do stop and chop or whether you will have to do the solute and remove it as a whole. But the hydro procedure plays a very important role over here. One has to be very gentle in rotating these pieces and also tackling this epinucleus so that if at all there is a dehiscence, it is not enlarged. So this is phaco in the epinucleus mode, where this epinuclear plate is completely emulsified and removed. So you saw, but if you see this, one is not sure whether there is a defect. We use the AC maintainer and the Dr. Lahane single port aspiration cannula, which is very comfortable. It maintains the fluidics very well. It maintains the posterior capsule behind, and there is no surge or there is no convexity, and hence it is a very, very safe technique. So there is this again, these are the few videos that we are showing you. This is the rexis. In here you can see a little larger rexis. So the rexis is very, very important. Break the rexis and you break the commitment to phaco emulsification. That is what I was taught, and that remains true even today. So as you can see over here, the nucleus is after the hydro procedure, it's a solute, and you can emulsify this as a whole, because sometimes finesse in phaco emulsification goes out of the window. But while doing all this, one has to be careful to see that you are protecting the corneal endothelium, and at no given time, I mean, one must try to see that the phaco is at the iris plane or just below it and not above it, to protect the corneal endothelium, which is extremely, extremely important. So here the suction is more than the ultrasonic power, because you want to aspirate this soft nucleus, and of course staying in the safe zone. The safe zone is within the circle of safety, which is within the circle of the rexis. So as you can see over here, so here you can see that Utratas forceps have to be used, because this is a very, very young patient and the capsule is very elastic and it runs away. This is a posterior polar cataract, as you can see. Use of Utratas or 26 number needle, anything that works. Even you have fine capsulorhexis forceps from made by my friend Sham from Epsilon, and no financial interest because he gives it to us free. So you see that this rexis is extremely important, and the elastic capsule may cause a lot of problems. So here again, multiple point hydrodelineation is important. And you see that once the nucleus gets hydrodelineated, it is so soft, it gets aspirated without using any phaco power. So directly into the phaco 2 is what is important. So there are various techniques, as we said, for soft cataract, the flip, the bowl, the flip and chip, the no chop, or whatever technique. You can name it with your own name and develop your own technique. So these are the various techniques which you use. So these are few more videos. If I have the time, I can continue this or we can end here. So this is again a hydrodelineation, as you can see very clearly, separating, keeping the epinucleus. The epinucleus is a buttress. So again the salute, lifting the nucleus, carouseling it, rotating it, and aspirating it completely. Here the aspiration is much higher than the phaco, and it is safer too because you're not using too much of energy. So this is how it is aspirated as a whole because it is extremely soft. Now, the bowl technique is not a technique, but somehow it inadvertently happens because here you are trying to use a chop and stop and chop, and this is the crater which is formed. So I don't, according to me, when this happens to me, I think it is extremely undesirable. And I'm sure that if with another trench, I would be very close to the PC or I would be trenching the PC. So you can go back. You can do a hydro and then ultimately rotate the nucleus and bring it. So here what is important is to rotate it like this and to bring it and to aspirate it as a whole. Because for trying to further trench the saucer would have created trouble with the PC. So, you know, having a bowl is not something that is desirable. That just tells you that trenching is not going to be possible and the technique needs to be changed. So this is again a very, very soft cataract, as you can see. And here the hydro is seen so beautifully, the multi-planar hydro procedure, as we can see over here, which is so clearly and very well demonstrated, and the salute of the nucleus. So, which is then going to emulsify it. So these are so many videos which show us the technique of managing this type of cataracts. And nowadays with patients wanting 6x6 vision, surgeons going ahead with doing refractive surgeries and removing cataracts, these cataracts are more often going to be seen. So as you can see over here. So what is important is patient counseling because these patients are very, very young. You have to change or adapt your technique differently. Posterior segment instrument standby is very, very important. So there are multiple techniques as we've already do what suits. That's what I always learn from sir. But always keep the safety of the patient in mind. Never to leave the safe zone for phaco in any type of cataract, but especially these soft cataracts because the peripheral will be even softer or thinner. Anterior chamber maintenance for proper fluidics is extremely important, and you have to use very, very low parameters to manage these type of cases. I really thank you and everybody for the opportunity to come and speak here again and connect with everybody. Last night, I think when I was meeting everybody, it turned out that by the next 4 or 5 Gujarat societies that Rana sir will be inviting me, I will be related to half the Gujarat Ophthalmic Society with relatives everywhere. So it's been a pleasure, sir, to spend time here. And thank you once again for the honor and the invite, sir.
Thank you so much, ma'am, for the tips. I will invite now Dr. Jagdish Rana, sir, Dr. Alpesh Rajput, Dr. Rupesh Shah, Dr. Kushal Deliwala, Dr. Path Rana, and Dr. Kalpesh Rajput to start his next session. Thank you so much, ma'am. Usually, the soft cataracts are very much tricky because we are overconfident. We want to finish the cataract very fast and start our next. But sometimes to finish the surgery fast, we end up with the complications. Yes. So it is more often seen that complicated patients are easy to tackle as compared to the soft cataract or the easy cataracts. I will invite every speaker to come on the stage. Madam, please stay on the stage. We will have a group photo. I would invite every speaker to come on the stage and have a group photo.
Gujarat Ophthalmological Society.
Celebration चालू हो गया.
Very good morning, everyone. I hope you all are ready for this international presentations. So, this is the first time we are doing international faculty presentations here, and we want to elevate the scientific caliber of AGOS. So now I am proudly announcing the first presentation of Dr. Barbara Parolini. She is well-known retina surgeon in all over the world. She is basically from Italy. She is director of Via Capellonia 70 Hospital in Italy. We all know her for her great work for macular buccal surgeries, for macular hole surgeries. Basically, she started first histopathological and immunohistochemical analysis of epiretinal proliferation associated to lamellar macular holes. And she started collecting and sending the membranes after peeling to Munich to the center of director of Christos Hospital, where it was run for histological and immunochemical studies. And they found there are two different type of epiretinal membranes for LMH. And she has developed the MTM staging system for that. And she has done a new description of use of macular hole buccals also. So she is going to do multiple presentations today. I would invite Dr. Barbara Parolini. Yes, ma'am, we can hear you.
disorder. We know that in 2016, my colleague Govetto in Italy differentiated the generative and tractional lamellar macular hole. And in 2020, the consensus was published on a new nomenclature and classification, as I will show in a minute. So this was the consensus, and when it was published, mainly I would like to focus on the definition of macular pseudohole, which is basically an epiretinal membrane with a small interruption in between, in the middle, and mainly the tractional lamellar macular hole, which is epiretinal membrane with foveoschisis, and what is now called in general lamellar macular hole, which was the degenerative lamellar macular hole, characterized by an irregular foveal contour and tissue loss. So we will focus today on these two entities, lamellar macular holes, the tractional and the degenerative. So the main difference is also the epiretinal proliferation on top of them. On one side, you see a tractional epiretinal membrane, on the other, what I call dense, but in history, it was defined in different ways: anomalous thicker membrane, dense membrane, LHEP, and now epiretinal proliferation. I think LHEP is not that correct because it is not associated only to lamellar, but also to full thickness macular hole and other conditions. So today we should speak about epiretinal proliferation on degenerative lamellar macular holes. Everything started, at least for me, with this observation during surgery. In 2008, you see the difference in peeling the membrane on the left, the typical epiretinal membrane with a tractional aspect, very elastic and consistent. On your right, you see this dense, fluffy tissue, very difficult to separate from the retina. At first, I thought I was peeling the fovea itself, but then I discovered that the internal limiting membrane was still underneath. So I decided to undertake a study to correlate OCT, surgical findings, immunohistochemistry, and immunohistology and histology. Today, we have both the staining and the intraoperative OCT, so we know exactly when we are peeling an epiretinal membrane and an internal limiting membrane, but at the time, we used to do everything without the staining, and we didn't have the intraoperative OCT. So I collected 19 specimens that turns out to be separated between, based on OCT, tractional and dense membrane. And we ran a study, as you can see, with histology and immunohistochemistry, finding main differences. As you can see in the tractional, we could find traces of internal limiting membrane and cells, smooth muscle cells, and collagen, while in the degenerative one, no ILM, masses of different collagen, very thick and rare cells, but only glia cells. We could confirm with immunohistochemistry that the cells in the tractional were mainly from smooth cells muscles, so with a contractile capacity, while in the degenerative type, we mainly had glia and hyalocytes. So now we know that most of the time when we peel the epiretinal membrane, we can peel the internal limiting membrane as well. As you can see, for example, in this image, they come together. Sometimes they don't, and we can verify with the staining what we are doing. But at the time, only histology could tell the difference. Let me skip this video for now. So another main difference was that we could peel both membranes, basically, with the aim to close the hole. But we found out that by peeling the dense epiretinal membrane, we had an increased risk of inducing a full thickness macular hole. So after having some of these complications, we suddenly stopped, thinking that it was a mistake to operate the lamellar hole with, as you can see on your right, with this kind of shape and the dense epiretinal membrane. And this was the publication on IOVS in 2011. And still, after so many years, in around the phobia. And most of the time, we can see that we can form, we can see the formation of epiretinal membrane and the schisis first, like in this case. See? But sometimes, sorry, let me move forward. See, you see the formation of the epiretinal membrane from an initial schisis, but also we can see the opposite, from an epiretinal membrane to schisis. So if this is due to displacement of tissue, we think that the treatment should be the removal of the membrane, but then should we remove the ILM, and should we leave an ILM flap with the aim to avoid inducing a full thickness macular hole? So in this case, you see that I was operating the tractional lamellar macular hole that you just saw in the OCT. I decided to peel the epiretinal formation, but then I decided to leave the ILM flap. This was a phase where I was really afraid to induce a full thickness macular hole. So I was basically experimenting what could happen to leave an ILM flap over a tractional lamellar macular hole. So let's see what happened. This was the result. A very bad result with irregular contour. You see the flap on top that the hole was closer than preoperatively, but the contour was still irregular. And as you can see in the progression, even after more than 1 year, the shape did not change. So the ILM flap does not have any remodeling. Where you place it, it stays. And it prevented vision. So once I observed that, after more than 1 year, I removed the flap, obtaining a regular contour with increased vision, like this. So I went from pre-op to irregular contour to irregular contour by removing the ILM flap. So my conclusion was that with the tractional lamellar macular hole, we should do the epiretinal membrane peeling without ILM flaps. Let's focus now on the degenerative type. Why do we have tissue loss, and what happens if we just observe these holes without operation? Let's see. The natural history is variable. It is described that this hole can heal by itself. You see a spontaneous resolution. This is published by a colleague of mine. but also they can develop a full thickness macular hole. They can turn into a full thickness macular hole, and at that point, they go to operation. Also, the opposite can happen. From a full thickness macular hole, you can see the reverse, the spontaneous closure and then lamellar. This patient was operated for retinal detachment with very good restoration of anatomy and vision. Then he developed a full thickness macular hole 2 years after vitrectomy. And as you can see, he had a spontaneous closure of the full thickness macular hole. But 2 years later, he developed a degenerative lamellar macular hole. Very, very strange. So these holes do not come from a PVD. This is the point. These holes happened when the vitreous was not there. This is another example. He developed a full thickness macular hole that then spontaneously closed, and then years later, he developed a degenerative lamellar macular hole. So it seems that there is a relationship between degenerative and nerve fibers loss. For example, you see this patient has a bad visual field in one eye, in the other eye, a very damaged visual field with a degenerative lamellar macular hole. And I have observed the same association between the degenerative lamellar macular hole and nerve fibers in patients, but I cannot have any proof at the moment, and this is still an open issue. So the problem with treatment, as I was mentioning, is the fear of inducing a full thickness macular hole with surgery, and that's why surgery stopped for a while in literature. And in literature, you see, in fact, the pros and cons of surgery, but that was due to the classic peeling. So if you do vitrectomy and completely peel the epiretinal formation and the ILM, you are likely to induce a full thickness macular hole. So the solution came by some colleagues that I worked with the idea of not peeling completely, but embedding the epiretinal tissue into the lamellar macular hole. So as you can see in this video, the epiretinal fluffy yellow tissue is peeled. Oh, I'm sorry that the video interrupted. I'm very sorry because my talk was I don't know what happened. I think I will have to reboot. Hello?
Yes, ma'am.
So you can hear me. I'm very sorry. I don't know why, but my computer has something wrong. Do you allow me to reboot my talk? I'm very sorry. It doesn't restart.
No issues, ma'am.
So maybe
You can go ahead.
I have to. Okay. I'm very sorry. My computer is stuck. So I have to reboot it. I don't know if, I'm sorry. I will have to disconnect and reboot the computer.
No issues,
I will
ma'am.
try to be fast, okay?
No issues, ma'am. Till then, we can go ahead for another presentation, and then you can again start from here.
Thank you. Thank you.
Yeah,
Thank
sure.
you. Sorry.
No
Okay.
issues, ma'am. Now, I would like to invite Dr. Sanyam. Dr. Sanyam Bajimaya, he's a well-known international speaker from Nepal. He is president of Nepal Vitreoretina Society. He is senior consultant, cataract and vitreoretina surgeon and Managing Director at Netradama Eye Care Center at Upandol, Lalitpur. I would like to invite him for the presentation. Sanyam sir. Sanyam sir, you are muted.
Hello.
Till then, I would like
Dr. Rana,
to
can you
ask
hear me?
people. He's not live now.
Yes,
Yeah.
I'm here. Yeah. Yeah, thank you so much. First of all, I would like to thank All Gujarat Ophthalmological Society for inviting me here, and really very interesting sessions. And I'm like to thank Dr. Rana also. So I'd like to share my presentation. It's right here, right? So is it okay? Hello,
Yes, sir. Yeah,
Dr. Rana.
you are live now.
Yeah. Okay, thank you so much. So I'm going to present a role of intravitreal steroid in diabetic macular edema. I do not have any financial contribution from this presentation. As we all know that the global prevalence of diabetes is projected to be rising almost 1.5 or twice by the year 2045. The number of diabetes population will be more in our part of the world, especially South Asian and Southeast Asian countries. And the burden of screening of diabetopathy and treatment will be huge in next decade. The diabetic macular edema is a leading cause of the vision sight-threatening cause of diabetopathy. And as we all know that 1 out of 10 patients, they might land up with a DME in our clinics. So as a pathogenesis, I'm not going to be detailed on pathogenesis, but hyperglycemia, it ignites the different cascades in the retina, like inflammations, blood retinal barrier breakdowns, drainage dysfunctions, and oxidative stress. And obviously, the drugs that we are using for intravitreal purpose has to address this whole chain of reaction that goes on in retina. One of the most important investigation tool that we do for DME is fundus photography as well as OCT scans. So this is very vital for our diagnosis as well as to see the prognosis of the disease. So when to treat and when not to treat all depends on the scans and visual acuity of the patient. So we treat with different anti-VEGF drugs, like in our current practice in Nepal, I'm using all the drugs except faricimab. And we have a lot of choices, but depending on the patient's insurance and patient's, the financial background, so we have to use, ranibizumab and bevacizumab more commonly than aflibercept. And steroid is one of the drug that was approved long time back, but in our practice, it's a magic drug that we are using, and implants that oxidation implant has, has bring us a game changing for the treatment of DME. And as we all know that we are using, we were using triamcinolone before, but now I'm using dexamethasone implant. And as compared to fluocinolone acetonide, the concentration of dexamethasone decreases by 2 or 3 months. So we have to re-inject dexamethasone implant after 4 to 5 months again. Whereas the acetonide, it remains for 9 or 10 months, and we can re-inject after 12 months. The main problem of the implant, the steroid implant, is the intraocular pressure issues and also the cataract. The EURETINA has a guideline for, there's a first line treatment with dexamethasone implant. And whereas in American Diabetic Association, they propose all the three drugs can be used for it, but depending on our choices. And the MEATS study was the game-changing study, which was first study to claim the dose of dexamethasone implant 0.7 milligram for purpose of treating DME. And the indications, there are some other indications of Ozurdex, but like non-infectious treatment, non-infectious uveitis, treatment for macular edema, secondary BRVO and CRVO, and treatment of DME. I inject the DME in the OR, in the operating room. I don't use it in the office procedure with all aseptic precautions and all using all the clinical protocols of the OR. So I inject Ozurdex very safely, and I assure patient that we are doing it very aseptically in the operating room. The collaborative study was done by the European DME registry study, and this was a landmark study, which is a very large number of cases were involved. And this study has shown that the injection of Ozurdex has very large improvement in the central macular thickness, and as well as the visual acuity. It improved in almost 1/4 of the cases, achieving 15 letters, whereas more than 1/3 had an achievement of 10 letters. So the use of dexamethasone implant is currently being practiced in our part of the world more commonly, and there are some studies which has compared the ranibizumab and dexamethasone implant, where the dexamethasone implant shows a stronger anti-inflammatory effects, and we have to monitor both intraocular pressure and also cataract progressions. And what is most important is post-cataract, especially in pseudophakic DME. It has a very, very important role for reducing the macular edema and also improving the visual acuity. When to use the steroid is very important. If the patient has unresponsive to anti-VEGF, or if patient is non-compliant or has very poor follow-ups, in those cases also we can inject the Ozurdex. Recent arterial thromboembolisms, pregnant patients, and chronic DME. And we should avoid using steroid intravitreal for a patient who has a glaucoma history and phakic eyes, or younger patients, a history of past ocular inflammations or ocular infections. And now we also practice combination therapy when we inject Ozurdex or intravitreal implants. So we have to redo injection of anti-VEGF also. So there are various studies so that if we inject even after 1 month of Ozurdex, or even after 2 months, it's a very rewarding that the number of injections of Ozurdex will be reduced. Also doing laser, I also do laser focal laser therapy and subthreshold laser for patients who have a recalcitrant DME or with the visual acuity. Even after injection Ozurdex, the vision has drastically improved, but there might be some leakage or DME that requires a laser treatment as well. This is one of my patient who is a young diabetic, 53 years old patient, and he had a very severe NPDR and DME in both eyes. We did an angiogram also, OCT scan also. So for which we seeing the CNPs, and we did a laser treatment PRP and also injection Ozurdex. And you can see the improvement in vision and also improvement of macular edema after injection Ozurdex in the right eye, as well as in the left eye also. We inject Ozurdex for this patient, and after 3 Ozurdex injection, he has a very good visual acuity, and also the outcome was very good. There was one more patient I would like to share. Is she's a young diabetic and had a proliferative diabetes with preretinal subhilar hemorrhage. And for this patient, obviously we have to do laser first, but seeing the macular edema, we injected Avastin. But since there was a progressive increase in the DME after laser, so we have injected Ozurdex almost for last 2 years. She received 4 doses of Ozurdex, and her visual is maintained to 6/12, and the macular edema is improved so much. So when to use an implant is when the patient is non-responder to Avastin or Lucentis, and the patient who are very good responder with dexamethasone implant, then we have to follow up them routinely and see how the treatment goes, and we can repeat it. But if those patients who are non-responders to dexamethasone implant, then we can also rethink of using Iluvien or the fluocinolone acetonide. So in conclusion, the DR is the leading cause of vision loss and blindness, and DME is the main cause of vision impairment. And although anti-VEGF therapy becomes a first line of treatment, but sometimes we have to switch to the steroid intravitreal drugs also. And combination therapy tailored to individual cases are necessary for optimal outcomes. Thank you so much. Thank you, Dr. Rana and whole team of Gujarat.
Thank you so much, sir, for the great presentation. Now, we would like to have some questions for you. Like, it is really
Yes.
great boon. There's all this steroid implants. They are really great. But have you encountered any cases where you have to remove this implants?
Hello. Yes. Yeah. There are a few cases where patient had a pressure issues, and I did not remove the implant. It was well managed with anti-glaucoma drugs. But there was some case I remember where glaucoma surgery had to be done, but I had not removed implant.
Any questions from audience? Thank you so much, Sanyam, sir. So now I
Yes,
would
Dr. Rana.
now I would like to ask
Thank you. If you want,
Barbara, ma'am.
I think I'm back.
Yeah, you can continue, ma'am.
Okay, so hopefully it will not happen again. Okay, I was about to show the removal, the surgery that I now propose for degenerative lamellar macular hole, which is the elevation, as you can see, of the fluffy epiretinal proliferation. Very difficult to peel and separate. It is nothing like the usual epiretinal membrane. So my advice is to pull and elevate the membrane all around the hole and without removing. And after completing the elevation of this epiretinal proliferation, you can stain again. You can see the view through the intraoperative OCT. Okay. And then you can stain and remove the ILM, which is still present as a confirmation that what you have removed is epiretinal. And then you create a big flap of ILM and leave it on top. You can see now the fluid air exchange and both membranes are still there. So by doing so, these are, in the summary, the basic steps, the elevation of the membranes, then peel and stop, and then the ILM flap and fluid air exchange. You see the pre-op on your left and the post-op on your right. So the results are extremely encouraging because you see a complete restoration of the foveal profile with increase in vision. So at the moment, I am advising surgery. Also, you can see the improvement from pre-op to post-op in microperimetry and central fixation. And it is actually better to intervene soon because if the break and the splitting reaches the outer layer, the increase in vision will be more limited. And also when the spontaneous improvement occurred, the final vision is worse than what we can expect with this type of surgery. So basically, the tractional and degenerative have, as you see, opposite behavior. With the tractional type, we need to remove both membranes because if we leave it inside, the hole does not close. The opposite happens with the degenerative type when if we remove, we induce a full thickness macular hole, and if we leave the membrane inside, it will close. So there is a hypothesis of a damage in the inner retinal blood barrier, which has not been proven at the moment, but it basically tells you that we don't know everything about this type of degenerative holes. It's not just about traction. So with the tractional ERM and schisis, we have a displacement, but here we don't have a displacement. We have probably, I think, a migration of tissue that could be a response, a repair mechanism to the generative stimula. As I show you, they can come after full thickness macular hole. It could be a repair mechanism. So then this type of membrane should be kept on top of the hole to restore the profile, both the epiretinal proliferation and the ILM flat. But if you do so, you will improve anatomy and also function. Thank you, and I still apologize for the interruption. So, do you want me to move on with the second talk, or would you like to ask some question on the generative?
Ma'am, we'll continue with the second presentation and we'll have the question in the end.
Okay, okay. So, so the second talk is still about interface tractional disease, but related to high myopia. High myopia is actually a very big problem because it's going to hit 50% of the population. Myopia is going to hit 50% of the population in 2050. And among this big group, high myopia is 20% and myopic maculopathy 3%. Everything runs around the concept of staphyloma. So the elongation, abnormal elongation of the eye wall, which I called scleroconus because it's totally similar to the keratoconus that happens in the cornea. And due to this scleroconus, all these bad things happen in the macula. And these eyes can degenerative in all these different shapes that you can see in 3D MRI, very large or elongated in specific spots in the staphyloma that can occur in every part of the eye, but we care about the posterior staphyloma. It's been shown that these eyes keep growing all their life. These patients have been followed for 26 years, and you can see a progression in the axial length.
Your presentation is not
eyes.
your presentation is you have to share the presentation.
You don't see the presentation?
No, ma'am. Screen is not shared yet.
Oh my God. So many technical problems today. I don't know why. Let me try again. Okay. I'm sharing.
Yeah, now it's coming. Yeah, it's
Now,
there.
yes?
It's there, ma'am.
Okay. So I will skip to the introduction and lead you to, I was saying that we are speaking about eyes with the staphyloma, and these are the 3D representation of the eyes with the staphyloma that can involve every side of the eye wall, but we care about the posterior staphyloma. And I was in this slide showing that a group of eyes was studied for more than 26 years, confirming that the axial length and the shape of the eye can change for all the life of this high myopic patient. And if this is the wide field of a normal fundus, this is the wide field of CT of a patient with high myopia. High myopia means higher than, longer than 26.5, but only some of them have pathologic myopia with disease due mainly to the staphyloma. So what is myopic maculopathy or pathologic myopia? Is these three aspects, the A, T, and N, atrophy, traction, and neovascularization, as described in the ATN classification. We will focus today on traction. that can be depicted not by color, but only by OCT. You see almost a normal high myopic fundus, but with the OCT, you see the traction. It's the only way. Let's see how this myopic maculopathy forms. It's basically due to the progressive elongation and tractional forces that disrupt the macula into all these types. I have studied for more than 15 years these cases with hundreds of OCT collected from my patient, and that is how I could put together the myopic traction maculopathy staging system, differentiating the progression, the stages of the disease from the inner schisis to the outer schisis in stage 2, to a combination of schisis and detachment in stage 3, to full detachment in stage 4. For each of the 4 stages, please focus on the inner fovea, which is intact in stages A. It has a lamellar macular hole in stages B and a full thickness macular hole in stages C. So to define the MTM, first you look at the macula and select 1, 2, 3, or 4, and then look at the inner fovea and select A, B, or C. For example, here you see an inner schisis, so it's stage 1. The inner fovea is intact, so this is stage 1A. In this case, the retina is fully detached, so it is stage 4, but the inner fovea is intact, this is 4A. In this case, there is a combination of schisis and detachment, so it is 3, and there is a lamellar macular hole, so it is stage 3B. A combination of schisis and detachment, stage A, with the nice fovea, stage 3A, so on and so forth. It's been published in 2020 and validated by an international community, just to highlight that it is easy to use and useful. So let's switch to treatment. Should we treat or not? Some patients are told not to receive treatment because of fear of complications, but let's go back to this image. If everything is due to the elongation of the eye, and if the retina detaches because it cannot follow the excessive elongation, so what does make more sense, to push and elongate the retina from the inside with vitrectomy, or to push and shorten the sclera from the outside? So in the history of the treatment of myopic traction maculopathy, everything started from the sclera 100 years ago. Colleagues were trying to shorten the eye in many different ways, but this surgery was considered very difficult and complicated, and then vitrectomy arrived, so everybody tried to solve every problem with vitrectomy, as you can see in the literature. But then what does literature report on success of vitrectomy? These are the average numbers: 60% functional success, 80% anatomical success, but the more severe stages are linked to anatomical failure. And I think this is what you experience as well, because vitrectomy has a high rate of relapse of macular detachment, high rate of reoperation, high rate of iatrogenic full thickness macular hole, higher use of silicone oil, and induced glaucoma. So again, you can see vitrectomy and macular buckle coming back because of the unsatisfactory results of vitrectomy. I started to speak about this in 2009, and these are my last publications in the last year. This is the last one reporting the results on a huge series of 206 eyes followed for 15 years, operated with the macular buckle. Because if you have an eye like this, which doesn't have a posterior staphyloma, it is large and has a mild schisis, if you do vitrectomy, you can be successful. But if you have this type of detachment and try to force vitrectomy, you will break the retina in between. And this is another case at high risk of full thickness macular hole with vitrectomy. And this is another case. So imagine what can happen if you push the retina down. This is what happened to this patient. It ended up in atrophy and full thickness macular hole. This is not a success. These are some of my publications on the subject, and this was the one where I was proposing how to treat each stage. You see, is the same table, but in red, I have added the management. So I was advising basically to treat with the macular buckle, the schisis and the detachment, and to reserve vitrectomy only to close the holes. So this is in summary my guidelines of treatment. It is very difficult to close the hole with vitrectomy because they are also very difficult to see when you look at the fundus for the lack of contrast, as you can see in these images. But if you want to close the hole, the ILM flap is the best way. But if you want to solve the schisis and the detachment, you definitely need the macular buckle. These are the buckles that I have developed in the ears, but I'm quickly going to the last model, which is this one. It is in PMMA, J-shaped. This is the black buckling part, and the holes on the arm allows to place the suture easily. This is the head now, how it looks. I'm making it thinner and thinner, actually. And I also design a loading device to make the surgical implantation easier. This is how the buckle and the loading device look when they are connected together. And this is in summary the technique. I open the superotemporal quadrant, isolate the superior and lateral rectus muscles, and then I implant the buckle, as you see here. So this is how to connect a light to use a transillumination in the head of the buckle. I connect the buckle to the loading device, and I just insert the buckle in the superotemporal quadrant and then tight the suture at the distance that it can be calculated with axial length, but then, as you will see at the end of surgery, this is the most important step, the checking of the location of the head that has to be under the fovea. So this is from a lateral view, the insertion of the macular buckle into the superotemporal quadrant while the eye is moved nasally. All right, like that. I made a study actually to correlate where to place the suture based on the axial length, finding a nice correlation between these measurements. But then I discovered that in the end, it's better to have a short, medium, and long buckle, so different sizes, in order to be able to suture always around 12 millimeters from the limbus, which is the most comfortable place. So over almost 400 buckles that I operated, I can show you some of the results. The anatomical results is 100%. If you place the buckle under the macula, there's no way to miss it. And most of them, if they don't have atrophy, will improve vision significantly. These are just some examples from pre-op to post-op. You see vision can improve 20/40, 20, even 20/20 sometimes if they have no atrophy, from pre-op to post-op, pre and post, and they are all like that. This eye was operated with multiple vitrectomy on your left. He came for the other eye that has this type of detachment, and just with the buckle, you can obtain this type of result. Another patient, very difficult to treat with vitrectomy, and this is the result after macular buckle. Even years it lasts. And this patient had the same stage in both eyes. You see the right eye was treated with vitrectomy, the left eye was treated with macular buckle, and this is the outcome. So you see when you place the buckle, you attach the retina, but with vitrectomy, he induced a full thickness macular hole. And then I retreated that eye with the buckle as well. So this is how the buccal eye look on the white one here on your left. On your right, you see the patient after multiple surgeries and glaucoma drops. So what about complications? The complications I face at the moment are some deficit, elevation, and diplopia, and some extrusion, but no major complication of vision. You can see here the improvement in microperimetry and also how the buccal appears in magnetic resonance. I don't do it in every patient, but I try to do it just to study the buccal in some of them. Some colleagues tells that the buccal might induce atrophy, but what you see here in the same eye is the natural evolution of atrophy in these eyes. Unfortunately, atrophy evolves naturally because the eye elongates. And I actually made a study on a large group of my patients studying the progression of atrophy in the operated eye versus the contralateral eye. And I could confirm that the buccal does not induce atrophy. You see some example from top to bottom here. 10 years after surgery, on your left was the macular buccal eye, on the right a vitrectomy operated eye. The buccal does not induce atrophy. This is another example with 7 years of follow-up, and this was published last year in Retina. I conclude with my best case just to show you that these are patients that can gain a lot of vision. This patient arrived with 2200, 32.8 axial length. He had a macular detachment stage 3A. I placed the macular buccal, flattening the retina, as you can see, 3 years after surgery. 1 year after phaco and multifocal IOL, he can see 20/20 unaided far and near. So this is what you can get with macular buccal and treating well the disease. Thank you so much. And I invite you all to come in November to Cancun for the EVRS meeting. Thank you.
Thank you so much, ma'am. It was great presentation. Now, we would like to know, ma'am, what are the chances of displacing this buccal? And if it displaces, we can replace it again, the same one?
So this is something that needs to be confirmed the day of surgery or within 1 week. If you use the transillumination and if you keep in your operating room a color picture of the fundus and then you look for, markers when you look through the lens, you need to locate the macula at the time of surgery. But for some reason, if you find the buccal decentered in postoperative time, remember that a mild decentration, like if the fovea is on the lateral side but still over the buccal, it will work anyway, no need to redo. If it is totally out of, if they don't match, fovea and macular buccal, if it is totally dislocated, it is better to relocate the buccal within 1 week. Otherwise, a fibrotic capsule will involve the buccal and everything will be more difficult. So my suggestion, what I usually do, I check the patient same day with the intraoperative OCT and then again 1 day after.
Thank you, ma'am. Dr. Kushal?
Yeah. Excellent talks, Dr. Parolini. So 2 questions from my side. So one is, you mentioned that you put the NPB buccal in the supratemporal quadrant. So is it surgeon's preference?
Yes.
Because a lot of times we see that the MRI you showed for the posterior staphyloma. So does the shape of this staphyloma help to decide the quadrant preference sometimes? And second question is that we
No.
Second question, ma'am, is for
No,
because
you always have
yeah, ma'am, go ahead.
Sorry, allow me to, I have some delay. I advise to always use the supratemporal quadrant. No need to do MRI. I'm just doing some MRI post-op just to study the position and location to revise and improve the shape of the buckle, but no need to do. You don't need to do it in real life. Always choose the superotemporal quadrant because you cannot go nasal. It doesn't make sense. And if you go in the inferotemporal, you will hit the inferior oblique muscle and the patient will have problem moving the eye. So the only place is the superotemporal quadrant. This is a standardized technique. And now, as I show you before, is really A, B, C, like we do in phaco, is if you follow those guidelines, you will have no problems at all.
Now my colleague Dr. Alpesh Rajput wants to ask you some question.
Hello.
Hello. Yes, madam. Wonderful
Yes, I can
surgery
hear you.
regarding the degenerative macular hole. You did a embellment and with the ILM flap. So how much amount of ERM should be embedded within, or you are using any different staining technique for the both ERM or ILM, or the same dye you are using? And one more question regarding, you are using any short-term tamponade like SF6 or C3F8 or a simple fluid air exchange?
Okay. So as far as the amount, I try to trim some of the excessive epiretinal proliferation. The amount I want is what is needed to cover the hole. You see, you put the yellow tissue inside the hole, and then it's covered. Just the amount that is needed to embed and fill and stuff the full thickness, the lamellar macular hole. I use the same staining. I use a staining that is based on lutein. Maybe you don't know it. It's I've been using this staining substance for 6 years, but I think it doesn't make any difference. Just to tell you what I use is at the moment it is distributed by Bausch & Lomb. It is double lutein. That is the name. So I feel very safe to stain and restain multiple times. And by the way, I just finished a study where I was comparing the effect of staining versus light on toxicity. And we could confirm, it was a very, very well done study. We could confirm that is the light the problem and not the chemicals. So I feel very safe by using the staining substance and have no fear of toxicity. So that's how I do. As far as tamponade, I don't think that you need any long term because everything happens in the first days. So maybe you could use air and just keep the patient face down for a couple of days. I usually inject 0.5 SF6 at the end of the fluid air exchange. So I know that the tamponade will last usually 1 year, 1 week, 10 days. That's it, no more.
Any more questions from audience? Thank you so much, ma'am, for sparing your time for us. It was really lovely presentation.
No, thank you, and I'm very sorry for the.
No,
Thank you. So I really apologize for the technical
no
problem.
issues, ma'am.
Usually it doesn't
Technical
happen.
glitch happens
Thank
all
you.
time. Yeah. Thank you, ma'am. Now I would like to invite Dr. Vignesh Raja,
Thank you.
sir. Yeah. Dr. Vignesh Raja is a consultant ophthalmologist and a vitreoretina surgeon at Sir Charles Gardner Hospital and Joondalup Eye Clinic in Australia. So, Dr. Vignesh Raja, you are live now.
Yeah. Sure, sir. Thank you.
Yes.
Sir, can you hear me? Sir, can you see my screen?
Yes, we can see your screen.
Yeah. At the outset, I'd like to thank Dr. Patrana for this kind invitation and the organizing committee of the Gujarat Ophthalmological Society for asking me to speak at the midterm meeting. So my topic is going to be vision beyond the ordinary approaches to difficult cataract surgery. So the difficult cataract surgeries that we come across, those are mainly cases with small pupil, dense rock hard cataract, intumescent cataract, posterior polar cataract, pre-existing PC rupture, or pseudoexfoliation and zonular dialysis. Of course, we would have other difficult cases like post-trauma, or complications during surgery. So again, for small pupil, there are different mechanisms that we can use. We could either do a mechanical pupil stretch, or we could use iris hooks, and there are different pupil expansion devices like the B-hex rings and the Malyugan ring. I'm sure in India, all of you are very, proficient in using these, so I don't need to, elaborate on these techniques. But then if you go to dense rock hard cataracts, there are, we can always do a good old SICS, and who better to do an SICS than the expert surgeons in India. So I'm sure all of you will do a fantastic SICS much better than I can do one. So we either, for dense rock hard cataracts, we can use an SICS or a phaco chop, a technique with lots of viscoelastics to protect the cornea. Here, this is a case where this dense dense brown cataract is actually sitting in the anterior vitreous face. So what I'm doing is I've made a scleral tunnel, and I've also pre-placed 4 ports here so that I can Gore-Tex fixate the scleral, Gore-Tex fixate a lens with scleral fixation. So I'm just removing the whole lens in toto because the lens is actually sitting in the anterior vitreous. And I stitch the port and then do a vitrectomy and then put a scleral fixated lens. So because that is outside the scope of the talk, I'll just, in the interest of time, I'll move forward. So the take-home message is, I think for a dense rock hard cataract, SICS is way better than phaco because it's the cornea is so much more clearer on day one compared to phaco. Now, going on to intumescent cataract, we always have to stain the capsule with vision blue or trypine blue, and then flatten the anterior capsule with dispersive viscoelastic, so Viscoat or Helon 5. I inject it so much so that the viscoelastic starts burping out of the wound. And when you are injecting viscoelastic, if you see, let me just put the video back, if you see displacement of liquefied cortex underneath the capsule, then we know that there is milky cortex. So here I'm just taking a 26 gauge needle on a 3 ml syringe, and I'm literally aspirating with bevel down. I'm aspirating the liquefied cortex here, and I move it around, and you can see the liquefied cortex comes out. And once this step is done, it is very important to go back in and refill with viscoelastic so that you flatten the anterior capsule as much as possible. And then we can either do a normal rhexis, or you could do a double rhexis where you start off small and then make it bigger as you go on. And there are some other very elegant techniques described, like the panchorhexis and all of that, where you can use a phaco, like a phaco on quadrant settings to remove it. So in this case, what if we get an Argentinian flag sign? If we get an Argentinian flag sign, then all we need to do is take 25 gauge vitreoretinal scissors to make radial cuts on the Argentinian flag, and then complete the rhexis on each side, and then proceed with phaco as normal. Otherwise, this is just a standard phaco, so I will proceed with the presentation. So then going on to posterior polar cataract, we have to make sure that we ensure a 5 to 5 millimeter rhexis, because in case we have a posterior capsule rupture, then we should be able to put a sulcus lens with optic capture. And like how Prof. Vasavada has taught us, we have to only do hydrodelineation in these cases and not hydrodissection. So here I'm making a 5mm rhexis and I'm doing a hydrodelineation. So you see the golden yellow ring, and then we proceed with normal phaco. The only tip here is we have to use viscoelastic prior to removing instruments at every step, just so that the posterior vitreous pressure does not cause the bag to split open spontaneously. So there are other techniques where people have done viscodissection as well to coat the endonucleus. So here I'm just proceeding with normal phaco, and before I come out, I inject viscoelastic as well. And then we do IA. And if you watch in this case, as I'm, some people suggest that we could use viscoelastic at this case so that you just cleave the cortex from the plaque. Here, as I'm removing the plaque, then you can suddenly see here that there is now a small posterior capsule rupture there. So I very gently remove the rest of it because with reducing my settings, now I'm injecting viscoelastic, dispersive viscoelastic, so that the posterior capsule doesn't, the rupture doesn't extend. And you can see now that it is already extended a bit. So now what I'm doing is I'm using 25 gauge vitreoretinal scissors with max grip forceps to make a circular posterior capsulorhexis. The tip here is you want to keep pulling towards the center as much as you can. So I've completed one side, and then it looks like the letter D. And so then I want to make it perfectly round. So I'm making a paracentesis on the other side. And then again, with the 25 gauge scissors, you can see that I'm making a small nick there. And with the 25 gauge max grip forceps, I'm again pulling towards the center as much as possible, to make a posterior capsulorhexis. The reason why I was doing this was this patient had high toric, needed a high toric lens. So I wanted to make sure that we put a lens in the bag despite a posterior rupture. So now what I'm doing is I'm just preparing another side port because I need to do anterior vitrectomy at the end, or just to check for vitreous at the end of the case. And I'm injecting the toric intraocular lens in the bag. So once that is done, then once I remove the viscoelastic, I put triamcinolone in the eye, and then I do anterior vitrectomy to make sure that there is no vitreous at the end of the case. And we can also always put Mycol or or myostat to make sure we have a round pupil. In the interest of time, I'll again go to the next slide. Now, one just show as soon as I put the vitrectomy instruments in. Now we put some Kennicott there. And now I'm just doing vitrectomy to remove it. Okay, and now the next case here is a pre-existing posterior capsule rupture. I think in the era of anti-VEGF injections, we will be coming across a lot of these cases, because here is a case a patient who had myopic choroidal neovascular membrane, and her posterior capsule was ruptured during the anti-VEGF injection. So again, here I treat this like a posterior polar. I hydrodelineate and not hydrodissect. And we have to insert viscoelastic at every step to prevent, flattening of the posterior capsule and the rupture extending. Again, this is a straightforward phaco. And once I remove this, again, we could either do a posterior capsulorhexis, but here it's already extended to the periphery. So all we do is optic capture, put a 3-piece lens in the sulcus with optic capture. In this case, what happens is once I I remove all of this, let me just forward the video. And once I remove all this, I then do an anterior vitrectomy, which is bimanual. We always have to start off with the cut IA mode and then do the IA cut mode, because the cut IA mode really removes the vitreous first, and now when we can either fold the three-piece lens or inject, a three-piece lens in the sulcus. My preferred method now is injecting, but this is a case where I folded the lens, and I think this lens was not warmed up in the cupboard nicely. So, the lens was not warmed up and it was cold. And now you can see that both the sides of the optic are now stuck. And so now I have to do bimanual separation of the optic in an eye with an open posterior capsule. So now I gently use the second instrument and the Kelman-McPherson to slowly, cleave the stuck optic. And then eventually it comes good. And then I found that whilst I was doing all this, I have put the lens upside down. It has turned upside down. So what I've now, once I disengage the optic, then I just, using the other haptic outside, I just twist the lens into its correct orientation. With of course, with proper viscoelastic. And once I do that, I push the optic down, do an optic capture, and then do vitrectomy at the end of the case. And this is a case with the zonular dialysis with blunt trauma, where this patient had more than about 6 to 8 clock hours of zonular dialysis. And she's got permanent, mydriasis as well. So this is her permanently dilated pupil, which is, even undilated, it is this. So this case, we didn't have to use dilating drops to do the cataract surgery because it was so permanently dilated. So now what I'm doing in this case is I'm making, I'm making multiple paracentesis, and I'm injecting viscoelastic to tamponade any vitreous that comes in. And in these cases, I find that it's easier to create the rhexis, to initiate the rhexis with the sharp instrument, either with the needle, with the cystitome, or with the side port knife. We always have to center the rhexis on the lens capsule rather than the pupil. So what I do now is I put the Chang capsule hooks now. What we have to do is we have to take care that we shouldn't put the Chang capsule hooks too close to the tearing edge, because if you insert it too close to the tearing edge, when you go back to restart your rhexis, the rhexis will run out. So I leave it at least 1 to 1.5 clock hours after, away from the tearing edge, where I can put the capsule hooks, before I continue with the rhexis. So always make sure to have a 5 to 5.5 millimeter rhexis as much as possible. So I'm doing that, and I've put two hooks for now. Then I do a very gentle hydrodissection and proceed with the phaco. And during phaco, we have to watch that the Chang capsule hooks stay engaged all the time, because sometimes when we use vacuum or aspiration, the Chang capsule hooks might get disengaged, and then it's defeating its purpose. It's not doing its job there. And I find that there is more than 6 to 8 clock hours of zonular dialysis during the case. So, I just think, okay, maybe at some point I should put another capsule hook as well. And if you watch the video carefully, you will see that the hook has disengaged at the top, not doing its job. So the temptation is to continue, but then I realize that it's not safe, because it is the whole bag is coming towards me as I'm doing the quadrant removal. So I'm now going to stop and inject more viscoelastic to inflate the bag and re-engage the capsule hook again with the bag. And now I think there should be another area of support as well. So I put another capsule hook, because this is almost about 7 to 8 clock hours of zonular dialysis. So we have to keep injecting viscoelastic at every step. So once I will fast forward the phaco side. So once I do that, then your tangential IA, because if you do radial IA, it causes more stress on the zonule. So we have to do tangential IA, which I'm doing now. And so once I do that, once I finish the IA, what I then do is I'm injecting viscoelastic in the bag. And then I'm using 25 gauge trocar, 2 millimeters from the limbus. So I put 2 of these 4 millimeters apart. So the distance between these two is 4 millimeters and 2 millimeters from the limbus. Now all I do is I just use one hook just to support the bag. And I'm taking a single Sioni ring with CTR and passing the Gore-Tex suture through the ring. Now I pass the Gore-Tex suture into the bag, and the Chang capsule hook is giving me good counter traction. And so that when we put the ring in, there is no worsening of the zonular dialysis. And we have to make sure that we put both the ends of the ring in the bag, and because if you put it in the sulcus, then it becomes quite technically challenging to put it back in. So now we slowly rotate the ring back to the desired position. And once we have the ring in place, then we don't need the Chang capsule hook anymore. So now I'm taking out the trocar and I'm using max grip forceps. You can use either 25 gauge or 27 gauge, and you can pull out any one of the Gore-Tex suture. You don't have to, we don't have to break our heads as to which one to pull. If you pull one, that should be fine. Any one is fine, because then we can just pull the other side and make it a loop. Again, I'm doing a handshake with the MST forceps in one and the max grip in the other, and this comes out. So once this comes out, then you can tie it either with a 3-1-1 or with a sliding slip knot. We can tie it with a sliding slip knot and center the bag. The only care that we have to do when we put these Gore-Tex sutures, so we could either use Gore-Tex, or you could use the Canabrava technique with Proline. The only thing we have to do is make sure that the Gore-Tex suture knot is internalized and not left on the conjunctiva. Otherwise, it will cause conjunctival necrosis and scleral necrosis and melting. Now I put a toric lens in the bag. And now, because this lady has a permanent mydriasis, I'm now implanting a human optics artificial iris. So I measure the limbus, and what I do is, let me again show you, when I measure the limbus, you have to take the measurements of the horizontal and the vertical corneal diameter and take the average of it and minus 0.5. And then use a Trifine to make the correct diameter of the iris implant. I'm also making a a peripheral iridotomy, and this injects through a 2.4 wound. So what I'm doing is I'm now injecting this artificial human optics artificial iris in the sulcus behind the stump of the original iris. And now I check for vitreous at the end of the case. And I stick down the conjunctiva with glue. And thank you all for your attention.
It was a great presentation, Dr. Vignesh. Thank you so much for sparing your time.
Yeah.
Any questions from audience?
Yeah, no, thank you so much, sir.
The material used to make this iris?
It's made of a silicone polymer. and it's very stable and biocompatible and very inert. You know, I've done more than 20, 25 of these now, and I've had corneal decompensation in only one patient who had extensive penetrating eye injury needing about 25 sutures in the cornea. And so she alone had corneal decompensation, but all the others were, are doing extremely well.
Yeah, because I had come across Russian people making of acrylic, you see. I say it's a heavy material for making iris.
Yes. Yes, correct. They do make it in Russia as well, but it is not FDA approved. But this one is FDA approved and comes from Human Optics in Germany.
And is there any other complications like angle closure or something due to that?
No, nothing, because you're putting it behind the stump of the normal iris or of the natural iris, and we're making a peripheral iridotomy. So there is no signs. You know, the main complications would be either a pupil block glaucoma or UGH syndrome. You know, because that's why sizing is very important. You know, we have to size it with, you can either use white to white and minus 0.5, or you take the average of the horizontal corneal diameter, take the average of that and minus 0.5 millimeters from that.
And is there any other method where we can fix it, this iris directly to the sclera? Like in case of any...
Yes, in fact, this human optics iris comes in two models. One is the fiber-free model, and the other model is with fiber. The with fiber model, I have lots of other videos where I can show you, where I have fixated them in a completely aphakic total aniridia eye, where I have fixated them to the sclera. I gave a talk at the AOS about 2-3 years ago where I showed all these techniques actually.
Okay. Any more questions from audience? Thank you so much, sir. Thank you so much for sparing your time. Thank you.
Yeah, thank you again, sir. Thank you for your invitation.
I would invite Dr. Kushal for his talk on faricimab. And this will be our last talk for this conference. And then we are going to have the bumper lucky draw after this. So please be there.
On it. Mic is not there. Slides, please. Good afternoon, everyone. So I would like to thank AGOC for this opportunity. So I will not take much of time for you all, as you are all waiting for the lucky draw. So we know that anti-VEGF therapy has revolutionized the care of the patients with retinal disease in the past 3 decades, and it is still ever evolving part, because a lot of newer even research is going on for the newer anti-VEGF molecules. But there are certain challenges which are unmet in the patients with neovascular AMD as well as diabetic macular edema. Those involve the patients where there is a financial as well as the other physical and emotional burdens on the patients as well as the relatives who come along with them. And then there is something related to the durability of this treatment, because it's a long and sustained treatment which the patient needs to take. Otherwise, a dropout in the treatment will lead to suboptimal outcomes. And regarding the molecules also, there are certain challenges faced, such as those which are multifactorial related to the etiology, because there are some components of the inflammation which is also involved in such cases which needs to be addressed too. So can we have an alternative therapies available where it takes into consideration this multifactorial aspect as well as the sustained durability of these molecules which are currently there in the available forums? So here comes one of the newer molecules, which is faricimab. That is being marketed by the Roche as by the trade name of Vabysmo. So the difference in this molecule is that it has got an anti-VEGF component as well as which is responsible for vascular leakage. But apart from that, it combines also the anti-angiopoietin 2 activity, which actually stabilizes the vessels which are leaking, as well as it also addresses the concern of the inflammation. So this dual property does make this molecule a bit of an interesting. So let us take a look at the trials which were done on the patients with the neovascular AMD. These were the landmark trials which were TENAYA and Lucerne. So they looked into the outcomes comparing with the existing molecule of aflibercept with regards to the visual acuity, central macular thickness, the span of interval between the two injections, and the most concerned part, that is intraocular inflammation post anti-VEGF therapy. So if we look at this, the vision gains from the baseline with faricimab molecules at 16-week interval of injections were non-inferior to aflibercept at week 40. With regards to the reduction in the central macular thickness, we can see that the molecule faricimab was at par with the aflibercept, even extending up to the week 112. With regards to achieving the longer duration of interval between the two injections repeatability, so we could see that greater than 60% of the patients could achieve the 16-week dosing with the faricimab, and more than 80% were able to achieve it up to 12 weeks, while the conventional existing anti-VEGF molecules need to be repeated every 4 weeks. And the most important part in these trials was that with regards to the intraocular inflammation and retinal vasculitis, the results were equal to the existing molecule of aflibercept, and they did not have any significant statistically significant outcomes. So same way, they also conducted the studies on the patients with diabetic macular edema, the Yosemite and the Ryan trial, which looked into the same aspects of the patients with diabetic macular edema. So we can see that the vision gains with the faricimab were again comparable with the aflibercept over the period of 2 years and with the fewer number of injections. Again, there was reduction of central macular thickness, which in fact turned out to be more better compared to the aflibercept at year 1 in the patients with faricimab, and it did maintain through the year 2. And again, the effect of the durability or the sustained effect, we could see that they achieved the significant prolonged injection interval that was up to the 16 weeks, and even more than about that, extending up to the week 96, they were able to maintain it up to the 12 weeks of repeatable injections. And again, it was well tolerated without any significant IOIs and retinal vasculitis event. So extrapolating these two data, they were able to achieve the US FDA approval for both the disease simultaneously, and taking into consideration the subtype of the patients with neovascular AMD, the latest trial which they underwent with the Salvin study, where they looked into the patients with polypoidal choroidal vasculopathy, which is considered to be a subtype of patients of neovascular AMD, and it was adapted from the same trials, the TENAYA and Lucerne for the neovascular AMD. And we can see the early response or the early outcomes of these results have been good for the patients at week 16, where they have showed robust improvement in visual acuity with plus 7.8 letters. And the major challenge in such PCV patients is that we don't get complete inactivation of these polyps most of the times. We do get leakage controls, but this molecule also help to leading to the complete closure and inactivation of the polyps in majority of the eyes. So now we have this dual inhibition of angiopoietin 2 and VEGF-A with the Vabysmo. So it does look like an interesting to help the patients to optimize the treatment outcomes, because it is taking into consideration all the unmet needs as of now. So let us look at the clinical real life cases which we have treated with this molecule. So here is a 84-year-old pseudophakic male who is a practicing lawyer, and he complained for blurring of central vision for past 1 week, and the right eye which was having a macular scar with an amblyopia. So because he was a practicing lawyer, he faced significant trouble with the only seeing eye of left eye. And here we can see the best corrected visual acuity was 6/24 and 18. On OCT, we can see a significantly elevated fibrovascular PED along with the subretinal hyperreflective material and neurosensory detachment. So patient was advised for intravitreal faricimab loading 3 doses. So patient took the first one, and we can see a significant response post first faricimab injection, and the visual acuity improved up to 6/12 and 8, and there was still some residual neurosensory detachment. But the most interesting point for this patient was there was significant reduction in the fibrovascular PED, the so-called wow effect, which was so far seen only in a molecule which is known as a brolucizumab, which has been made by the Novartis. So the second injection was given to this patient, and in between, because of certain health concerns, he was not able to come for follow-up exactly after a month, and he came after 2 months, 2.5 months, but still his visual acuity was 6/9 and 8. And there was some reactivation of the lesion where we can see that subretinal fluid had increased, but definitely we had to go ahead with the third injection of faricimab. And now we can see that patient has got a good outcome, 6/9 and 6 vision, and there is absolute drying of the subretinal fluid with a significantly achieved reduction in the fibrovascular PED. But this patient are still under follow-up every 2 months to see whether there is any reactivation or not. Another case of a 72-year-old pseudophakic male where the right eye had a blurring of vision for past 10 days. Patient was having left eye also treated for wet AMD before 8 years and had a macular scar. So practically again a kind of a patient who was a one-eyed patient. Now there are a lot of concerns addressing such newer molecules where people also talk about whether to give them in one-eyed patients or not. But considering the data available in the public domain and a lot of publications available in the index journals, we can definitely say that it is worth to give them the best outcome for their only seeing eye. So we have to take this into consideration. We can see here the presenting visual acuity was 6/12 and 10, and there was again a huge fibrovascular PED with neurosensory detachment. So this patient also was advised the same faricimab intravitreal therapy for 3 loading doses, and patient is still under follow-up, and we can see after first month itself there is a significant reduction in the fibrovascular PED height as well as a significant reduction in the subretinal fluid. So the patient has been injected with the second faricimab, and his patient is due for follow-up. So initial loading doses does require giving this injection at monthly interval, and after sustained effect of these injections, we can extend them to the initial 8 to 12 weeks of repeat injections, and we can observe them as well as extend according to whether there is any activity in the lesion or not. So thank you very much for patient hearing.
Kusal, your comparison with ILIA?
Yes, sir.
Comparison with ILIA?
Definitely, sir. The trials were compared with the ILIA, that is aflibercept, and the results were found to be non-inferior. And in DME cases, we can see that the central macular thickness had a significant reduction compared to ILIA itself. But overall, if we see that the sustainability compared to the ILIA, so ILIA is able to achieve only up to Q8 or Q12. That is, you inject them every 2 months or 3 months, but the faricimab over a longer period, you need to inject them only after 3 months. So the major challenges of repeating them every month, patient has a reduced number of follow-ups, the tolerability will be good. So obviously the financial challenges will be there. If patient is not having financial challenges, then the first preference now becomes a faricimab, because we have got an ample data available to show. And the initial therapy where people used to say that it gives a very slow and sustained effect, but in these 2 cases we can see there was a significant improvement within the first injection itself. So given a choice where there is no significant difference in terms of the financial burden compared to the Vabysmo in the ILIA, we can opt for Vabysmo if patient is ready for that.
Wonderful. Do you have experience with the DME, particularly with the faricimab? Because this drug is really working for the intraretinal fluid, subretinal fluid, or just reducing the PED height?
Yeah.
So do you have any experience of that?
If we talk about the DME patients, I always see it as a multisystemic disease. It's not an local disease. See, neovascular AMD will have better results because it's a local disease where the inflammation is limited only to the retinal aspect. But DME needs lot of parameters, like we need to see their systemic controls and other aspects also, like comorbidities, nephropathy, etc. So my primary experience with DME is a bit limited, but I can definitely vouch for the neovascular AMDs, because DME I see them as an holistic person. So unless you don't take into consideration the other aspects, you might get suboptimal response, and you then start thinking of switching to other molecules.
Thank you so much, everyone. And now I would like to invite Dr. Saxena sir for closing remarks.
Along with this last lecture, we conclude this scientific session. And thank you all for attending conference and make it very grand success. And before we go to Lucky Draw Prize, I invite Dr. Ashish Shah and Dr. Parth Rana for cake cutting on the dais. So both please come on the dais and for cake cutting, yeah.
I would like to invite Dr. Kushal or Dr. Rupesh Shah sir. You can present the certificate to him.
Okay, it's by mistake actually. His birthday was on 14 June. So belated happy birthday, but still you can come and cut the cake. No, everybody can't come here.
I invite all LOC member of midterm to come on the dais to have a cake ceremony. Please, all committee members. And Dr. Jignesh Gosai's son is also having birthday today, so he's all invited with his son. Please come on the dais. All committee members of midterm AGOC, please come on the stage.
Rupesh sir, please.
कोई चाबी का टट्टू और दुनिया कहती है हैप्पी बर्थडे टू यू।
Within few minutes, we are going to start our lucky draw. So you can circulate the message in your group and call your friends and colleagues to be present in the conference hall. While announcing the name, those who are going to be present in the hall, they only are going to get the gifts. So please circulate the message in the group that please be in the conference hall right now. We are going to have lucky draw for trade partners also. So all trade partners are invited for the lucky draw. First we are going to do delegates lucky draw, followed by trade partners, and after that final bumper lucky draw.
Hello. Good afternoon, everyone.
Hello. So, first of all, I would like to invite our food management committee to pick the chief. Dr. Sanjay Govil, Dr. Bhavesh Patel from Jamnagar, Dr. Ankit Shah from Himatnagar, and Dr. Jignesh Jeshwal. Please come on the stage. So, Dr. Mihil will announce the prizes.
First of all, we are conducting the draw for the doctors delegate. First prize from the Zebronics Power Bank MB 10,000 S15. Let's see who is the lucky one. Dr. Himanshu.
Hello. Dr. Himanshu Jodani.
Congratulations, sir. The next gift is the same one, the Zebronics Power Bank 10,000 mAh battery. All the best to everyone. And Dr. Niranjan Mode. Congratulations, sir. Again, the same gift. Let's go for the. And the winner is
Dr. Bhargav Kotadia.
Dr. Bhargav Kotadia. I think he is not available, so we have to pick up the second one.
Dr. Bakulis Khamar, sir.
Dr. Bakulis Khamar, sir. Congratulations, sir, please. We still have the another round of the same gifts, Zebronics Power Bank.
I would request our transport committee, Dr. Meet Ramani, Dr. Sapansa, Dr. Jatin Mewada, Dr. Mitesh Kokhani, and Dr. Bhargav Kokodia. તો સર પાછી જ ઉપાડ દો તમે પાવરફુલ એટલા બધા છો ને કે આ પાવર બેંક નો કઈ પાવર ના લાગે આમાં
Sir, चिट्ठी उपाड़ता जाओ, please. Now the lucky draw for the 65-watt fast charging 4-in-1 sparing data cable. Dr. Bhavik Jala, sir. स्कूटर गયું બતા દે સાહેબ પ્લીઝ ચિઠ્ઠી ઉપાડીએ ઓકે કોને બોલાવે Or now I'd like to invite the accommodation committee members, Dr. Bhavik Jala sir, Bhumik Rawal sir, Dr. Dhaval Shah from Bhuj, Dr. Jay Prakash Purohit sir, Dr. Kanisha Kotadia. Is there anyone available here? Okay. Okay. आप बताओ ना, नहीं बताइए। This is for the power bank, Zebronics power bank, MB 10,000 mAh.
Dr. Neha Rupesh Shah.
Dr. Neha Shah, congratulations, ma'am. Again for the same gift. Let's see.
Dr. Kruti Shah.
Dr. Kruti Shah is available. Yeah, please. I would like to invite the transport committee of the conference, Dr. Meet Ramani, Dr. Sapan Shah, Dr. Jatin Mewala, Dr. Mitesh Khokhani, Dr. Bhargav Kotadia. Okay, fine. Audio visual. Audio visual. Audio visual committee, Dr. Alpesh Rajput, Dr. Dhaval Rajpara, Dr. Ankit Shah, Ahmedabad, Dr. Alap Bavishi, Dr. Mehul Patel, Himmatnagar. Please come on, guys. Wire. This is the 4-in-1 cable. Same, 65 watt charging cable.
Dr. Bhavesh Patel.
Dr. Bhavesh Patel, sir.
Jamnagar. Bhavesh Patel, sir. Jamnagar.
From Jamnagar. Sorry, sir.
Dr. Prakash Rathod.
Rathod, sir.
Prakash Rathod, sir.
Available. Same. बताइए ना बताइए.
For the same gift,
Dr. Divyang Brahmat, sir. Not available.
not available. Next.
Next one.
Dr. Sunal Agrawal.
Yes.
Congratulations, ma'am. Again for the same gift, we are picking up the cheats, please. आटलू पता होना चाहिए.
The dashing Dr. Narendra Verma.
Again for the same gift. Dhawal bhai. Yes. Dr. Akash Patel, Vishnagar, but he's not available. Dr. Mohak Shah, not available.
ડબ્બા બટલે જ બાકી રહી છે.
Dr. Kushal Deliwala.
Congratulations, sir.
આ વખતે નાનામ પત્યું.
સર એક વખત કાર મળી છે, આ વખતે નાનામ ચાલશે.
Dr. Harshita Saxena. Dr. Harshita Saxena.
Dr. Harshita Saxena. અહીંયા નથી.
આપી દો વાંધો નહીં.
આપવાનું
આપી દેવું છે.
The power player, Dr. Ashish Saxena.
હજી એક કાઢો. Dr. Kamlesh Kalaria. Not available. બીજું ઉપર આવે. Dr. Bhartiben Patel. Now would like to invite an entertainment committee, Dr. Akash Patel from Visnagar, Dr. Jitendra Vidhani, Dr. Jignesh Gosai sir, please come on dais. Okay. Now we are going for the lucky draw of 65 watt fast charging 4-in-1 sparing data cable. We have 2 gifts from the same item.
And the lucky winner is
Dr. Romil Patel.
Wow.
Romil. Yes.
Sir, again for the second one, please.
Dr. Anand Dave. Romil.
Dr. Anand Dave, is he available here? Okay, better luck next time. Sir, please again.
Dr. Jitendra Vidhani.
Dr. Jitendra Vidhani, sir.
वो भी निकल गए.
આવે છે તો એમના માટે રાખીએ કદાચ. એના ઉપર જ. Sir, please, જી એક છે. This is for the safety hammer to use useful in the car. આ ત્રણે કર.
Dr. Bharat Dabi.
Dr. Bharat Dabi, sir. Please. I would like to invite Conference Advisory Committee, Dr. Hitesh Ramanuj sir, Dr. Ashish Bojak sir, Dr. Dikesh Gohil sir, Dr. Nutan Shah, Dr. Kamlesh Kalaria. Please come on dais. Nutan ma'am nikdi gaya. Please ma'am. We have 3 pen drive, 64 GB pen drive from the SanDisk.
મારે આપવાનું છે લેવાનું નથી.
Please ma'am.
Dr. Ankit Shah, Himmatnagar.
Dr. Ankit Shah,
Himmatnagar.
Ma'am, please.
Dr. Kanisha Kotadia.
Not available.
Nothing. Dr. Amrut Patel.
Not available.
Absent.
Please, ma'am.
Dr. Apurva Dutt. Apurva Dutt.
Dr. Apurva Dutt. Yes, please welcome, sir. Sir, again, for the same gift. Upara. Ma'am.
Dr. Mukesh Singhania.
Dr. Mukesh કાલે આવે છે ઓકે ફાઇન સર આપી દો એટલે એ આપી દો પેલી તો મેમની પાસે છે બે એક again for the Protronics 30 watt max output charger can be useful in the car.
Dr. Hitesh.
Dr. Hitesh Raman sir. Sir, ma'am, please.
લાગવગ લાગી એમને.
Sir, again for only one
હવે તમારે લેવાની. મારું ગોતો.
ઋત્વીબેન ભાવિન કુમાર પટેલ.
Dr. Rutvi. Okay, fine. Now we are going to Now I would like to invite co-treasurer of the conference, Dr. Siddharth Gosai, Dr. Himanshu Jodhani. Please come on dais. Now we'll go for the lucky draw of Petronix Freedom Fold 15 watt wireless charger. Please, sir. We have four number of gifts from the same item.
Dr. Nikul Sathwara.
Dr. Nikul Sathwara.
He is absent. If Acha, okay. He is present, but right now,
Dr. Nikul Sathwara. Okay. Okay. Dr. Khushbu.
she was absent.
Dr. Sanjay Govil.
He is also not present. वही करना.
Dr. Amit Shah.
Not available.
Dr. Siddharth Gosai.
Please, sir.
Sir, please.
સૌથી બેસ્ટ હોય.
ડોક્ટર દર્શિન બાવીસે.
Absent.
ડોક્ટર અલ્પેશ રાજપૂત.
ये congratulations. आई जाओ, आई जाओ, आई जाओ. अल्पेश राजपूत.
अल्पेश भी राजपूत.
ગયા. સ્કૂટર ગયું. અચ્છા.
Dr. Jignesh Gosai, sir.
Now I'd like to invite conference treasurer, Dr. Bhomik Rawal and Dr. Rupesh Shah, sir. Please come on dais.
Next.
Now we are going for the lucky drop Zebronics wireless car charger. We have two gift of the same company.
So the lucky winner is Dr. Nimisha Patel.
Congratulations, ma'am. Sir, please.
હું આપી દઉં.
એક વખત દીકરીનું કાર્ડ નથી મળી. ડોક્ટર પ્રિયંકા અગ્રવાલ.
Dr. Priyanka Agrawal. Yes, please, ma'am. Congratulations. Now we are going for the Patron Fusion Tuner 10 watt mini Bluetooth speaker. We have two speakers from the same company, please.
So the first lucky winner is Dr. Shail Vashavda.
કાલે આવ્યા હતા.
કાલે આવ્યા હતા. Yes, okay.
શૈલ શર્મા દ્વારા.
Sir, જતા રહ્યા. For the same gift, Dr. Dhaval Rajpura. ગીતો ગાવા લાગો હવે. એક આમાં ગાઈને બતાવવું પડશે તો જ આ ગિફ્ટ મળશે.
Now I would like to invite a conference scientific committee, Dr. Kushal Dehliwala, Dr. Parth Rana, Dr. Keshvi Shah, Dr. Ashish Gajja to come on dais, please. Now we are going for the lucky draw for the Zebronics Zap Pod. It's a wireless headphones.
Dr. Rupesh Shah.
Dr. Rupesh Shah. Please, you are the winner. As a winner, you are inviting, please, sir. Kushal, sir.
ડોક્ટર વિનાયક જીવાની.
વિનાયક જીવાણી છે અહીંયા છે. હા.
These are open ear pods, so you can use it while exercising also. So specifically designed for you.
હમણાં ભાઈ કરાવી દઈએ ને સભા બાકી હશે. Now we are going for the lucky draw of JBL Bluetooth speaker. ના જી હવે
ડોક્ટર ગૌરવ મહેતા.
ડોક્ટર ગૌરવ મહેતા.
કોંગ્રેચ્યુલેશન.
Now I would like to invite a joint secretary of the AGOS conference, Dr. Mohak Shah, Dr. Vasavada sir, Dr. Gaurav Mehta, please stay in guys. Dr. Sanjay Patel, Dr. Aditya Desai, not available. एक ऊपर चिट्ठी से
ડોક્ટર પરેશ ઠક્કર.
ડોક્ટર પરેશ ઠક્કર.
Yes, congratulations.
Now, mobile phone and scooters are left for delegates. Now we are going to start for trade. So,
Now I would like to invite a co-chairman of the conference, Dr. Bhavesh Bhai Patel, Dr. Prakash Rathod, please come on stage. Dr. Bhavesh Patel from Palampur. આવી જાઓ તમે આવી જાઓ જામનગર વાળા આવી જાઓ.
delegates માં કોને કોને બાકી છે હજી? કોણ કોણ હજી લકી છે?
ડેલિગેટ્સ વાળા અહીંયા કેટલા છે?
સો આટલા લોકો સ્કૂટર માટે અને મોબાઈલ માટે
અલ્પેશભાઈ આવી ગયો હવે. બાકી વાળા
દીક્ષાંત સિંહ સાહેબ ના ચાલે, લાસ્ટ ટાઈમ જીત્યા હતા. દીક્ષાંત સાહેબ તમે લાસ્ટ ટાઈમ જીત્યા હતા, આ વખતે ના ચાલે હવે.
હવે now we are going for the trade, we are going for the lucky draw for the trades. Sir, please. એ કઈ કઈ છે? The 30 watt max output charger for the car.
Love you, Pharma.
Love you, Pharma.
Love you, Pharma.
Any representative from the Love you, Pharma?
આપી દેજો.
Okay, Love you, Pharma લાવો ને.
લાવી વાળા ફરવા જતા રહ્યા છે.
Love you, Pharma.
ચાલો પેલા એક મિનિટ પાછળ લગાવી.
Sir, please ખોલો ને. Neomatics. Any representative from Neomatics, please come on dais. Now for the Zebronics wireless car charger. સાહેબ ઉપાડતા જાઓ. કાર ચાર્જર છે ઓલું વાયરલેસ ચાર્જર.
BKC Pharma. BKC Pharma.
BKC Pharma. BKC Pharma. ભૌમિક શાહ. BKC Pharma. એ માણસ હતો. Lupin Pharma. Please come on guys. Are you ready? Now we'll go for that SanDisk 64 GB pen drive. Sun Pharma. Any Sun Pharma representative, please come on there.
कौन से डिवीजन वाले आएंगे? वो तो फाइट नहीं हो रही ना. आ जाओ आ जाओ. अच्छा पहली बार
Again for the SanDisk pen drive.
Zivira Pharma.
Zivira Pharma. Please. Now we'll go for the high-speed data charger. Sir, please pick up. હજી 3-4
Mankind Pharma.
Mankind Pharma. Any representative from Mankind Pharma? આપી દે Mankind વાળા.
ના એ Mankind નથી.
કઈ વાંધો નહીં. સ્લાઇડમાં રાખો ને Mankind. સર પ્લીઝ તમે ખાલી બે ઉપર લગાવો. Ocean Pharma. Ocean Ophthalmics. जी ले लो. ठीक है. Sir, please. Now I would like to invite our chairman of the conference, Dr. Mukesh Bhai Patel from Mehsana, Dr. Narendra Singh Verma. Please come on stage. Mukesh Bhai.
Appasamy Associate. Appasamy.
Narendra sir, please.
Bayer Pharma.
Bayer Pharma. पहुंचा देशो.
Bayer Pharma. हाँ yeah.
Sir, please. Mukesh bhai.
No.
This is for the safety hammer we can use in the car. Ajanta Pharma.
Ajanta.
Biotech.
Biotech. Please.
आप दीजिए.
Now we'll go for the fuel, the compact power pack, okay, battery, okay, pocket size lithium battery, power bank. 3 in numbers, 3 je.
Hazel Pharma.
Hazel Pharma. Hazel Pharma.
अरे
बोले पावर बैंक, फ्यूल पावर बैंक. केयर ग्रुप. अच्छा केयर ग्रुप लाओ तुम.
NRI.
Now for the Zebronics power bank. Zesta Care. Now for the Zebronics airport, almost.
His Highness.
Check. Now the bumper one, Motorola Moto G5. And the last one for the trade. Mobile kiddo ne? Motorola 05. Smartphone. And the lucky one,
Newgen. Okay.
okay.
Now it's over for trade, and now we are going for mobile phone for delegates. Mobile phone.
I'll invite Dr. Bakules Kamar, Dr. Bakules Kamar, sir, only present from the patron, to do the cheat. Dr. Mayuriben Kamar, please also come.
Now this is for mobile phone, Samsung Galaxy A05 with dual 50 megapixel camera and 5000 mAh battery and 25 watt fast charging.
We'll invite Dr. Sasank Patel also. Please come on the dais. Now one mobile phone and two scooters. So they are the three senior person who will decide the luck of a delegate. Khamar Sahib નું નામ લાગે છે આમાં. સર આવી તો મયુરબેન નું હશે. ડોક્ટર મુકેશ પટેલ और मोबाइल फोन. વાહ. સાહેબ નું કેવું છે કે નાસ્તો ખોળ્યો.
Mobile phone idol.
મુકેશભાઈ ના પાડતો તો જાઓ નહીં, નીચે ના જાઓ સાહેબ.
વચ્ચે જ આવી જાઓ, બધાની વચ્ચે આવો.
મને નાસ્તો ના કરાવે એટલે કે ના
સર બાકી દે. Now two electric scooter, Nova Pro. So one cheat by Dr. Mayurben, second by Dr. Sasank Bhai.
શક્ય છે.
કલ્પેશ રાજપૂત.
આખી રાજપૂત ફેમિલી આજે ગિફ્ટ લઈને જઈ રહી છે.
રાખો ને.
Last bumper prize scooter. Dr. Parth Rana.
Since I was young, they said I will mean nothing. Congratulations. Work so hard for vacation. People hate and say we're changing, losing. Yeah, we made it. That was never friendly, yeah. Now I'm jumping out of Bentley, yeah. And I know I sound dramatic, yeah. But I know how to have it, yeah. For the money, I'm a savage, yeah. For me, it sound like I have it, yeah. Surrounded 20 babies. Congratulations and jubilation.
Thank you everyone for your whole support, and we will continue this tradition next year also. So looking forward for all your support. Thank you. Now we will proceed for the lunch.
Please, all committee members are requested to come on stage for a group photograph. Kushal bhai. Jignesh bhai, Ankit bhai, come. Mukesh bhai, come. All committee member. Dhawal bhai. Dr. Prakash Rathod. Prakash bhai, come. Committee member. So no. So.
જેને ના મળ્યું એને પોતે
જોતા